Good evening, ladies and gentlemen, colleagues and friends. Thank you for joining us again at another SPG webinar. Joining me tonight are once again my colleagues and partners in crime. I'm really excited that today we've got a whole gang here of all of us. So you're going to have 5 prosthodontists tonight. Starting from my left, we have Dr. Ghada Soliman.
Hello.
Dr. Agnes. Hello. Dr. Zoe Potres.
Hello.
And Dr. Johnson Chou.
Hi.
For the ones that don't know Dr. Ghada Soliman, she has joined the practice. She's the latest addition to the practice. Almost 2 years now, Ghada?
2 years, yeah.
Something like that.
Yes, in March.
Yeah. So
Gone
for
very quickly.
It has.
Yeah.
It has. What has this journey been like for you so far?
Amazing, challenging and amazing.
She's only saying that because we're live. For the ones that don't know Ghada, she was already a prosthodontist back in Egypt. After a couple of years, she migrated to Australia. I guess prosthodontists was so kind to her, she decided to do it again at the University of Sydney. So she's now, I guess, twice registered in 2 continents. So I think she's twice as good as the rest of us.
Thank you. I just had a lot of money. Always I say, I had a lot of money, a lot of time.
Whatever works.
Had to do it.
Whatever works. So no, I feel completely blessed that you have joined the team. So thank you.
Thank you. Thank you. It's my blessing.
So tonight's webinar, of course, is live and interactive, and that means you get to send in all your questions. And I'll do my very best to pass on these questions to the panel. For the ones that you've already joined us previously, you know, we have a format, a program tonight, so I'll be directing the appropriate questions at the appropriate time. So for example, we're talking about bonding and cementation last, and so I won't be directing that type of question to the panel at this stage. But please do feel free to send in questions, because I've already seen quite a number of questions, and once again, I'll do my very best. For the ones that wants to receive your CPD certificate for tonight, so please scroll down all the way to the bottom of the page where it says, enter your email address for CPD. Please do not forget to do that, otherwise you won't get one automatically. Of course, for the ones that has missed some of our previous webinars, feel free to check it out on our website, www.sitpg.com.au, for all the past recordings of our webinars. I've even got a QR code here on screen. Feel free to take a screenshot of that, so you can just hold on to it in Chrome, and then that will get you directly into the page of all our past webinars, which I think many of you guys will find it quite helpful. Tonight's presentation, like always, it is sponsored, but that is just to cover the IT cost with Articulate Media, headed by Mr. Brett Tyler. For the ones that you know him, he's a true professional. So that's what that sponsorship is all about. But none of the speakers here, we don't receive any honorarium for these presentations. It's merely a chance for us to share with you guys what we have learned as a result of treating your patients. There's no endorsements and kickbacks for any of the products that's being mentioned. And last but not the least, of course, all the materials that we're presenting here are our own personal opinion or expert opinion, however you like to call it. So please do exercise discretion on how you're interpreting these information. And all the cases we've shown here, of course, can vary or differ from other treatment cases that you may wish to do. Just a quick couple of words on our sponsors. Number one, Noble Biocare. As you will know, they've been a long-term sponsor of ours. We have a very long professional relationship since the day one of my prosthodontics degree, actually. For the ones that it was interested in a little bit more implant learning, so there is this Noble Biocare mentorship program, which I'm the course convener for. This is going to be our 4th year running this program. It's a year long, but it's separated into 4 modules. So 3 days each module, in total 12 days. Very hands-on heavy. There's 4 sections or 4 modules, starting from planning, digital planning, how to construct a surgical guide. Into module 2, how to surgically place a routine implant with or without a guide. And then module 3, how to restore implants. And finally, learning some more complex stuff involving GBR, sinus lift, and touched on full arch rehabilitation as well. So it takes you from the very beginning, if you're a beginner or an intermediary level in terms of implant treatment, this might be the right course for you. For the ones that's interested in the program, once again, you can use that QR code and it will get you directly to the right page, or you can simply just do a quick Google of the Noble Bowel Care Mentorship Program, and I'm sure you'll find that. Our second sponsor is Dyneck. For the ones that's looking for high quality handmade sutures, then this, I think, company is the right one for you. I previously thought all sutures were just automatically made by machines, but no, they actually hand knead every single suture to give you that consistency. So I've personally been enjoying using a large variety of their absorbable and non-absorbable sutures. So for tonight, for all the viewers, I think there is a promo code if you scroll down, but otherwise, if you make a purchase, they give you guys 15% off, which is pretty good. For the ones that's joining us for the first time, or you don't know much about who we are as a group, well, Sydney Prosthodontic Group, we are a group of prosthodontists, and now an oral surgeon, Dr. Tao, as well. We're in the center of Chatswood, and we're a specialist practice that's sharing our space with a group of endodontists and periodontics. So under one roof, we can tackle some pretty complicated cases. Especially I love the corridor consultation where you can quickly grab a mate and get a second opinion, which is very, very helpful. So I've certainly been learning a lot from everyone over the years. And to cater for all the patients that we've been receiving, we basically ran out of space. So we've expanded, still in the same building, just on a different floor. We opened up our new premise just earlier last year so that we can see your patients much quicker. And on behalf of the entire group, we want to thank each and every one of you guys tonight for trusting us to deliver the right care to your patients. We really appreciate it. So without you guys, we would simply cease to exist. And that's part of the reason why we're doing what we're doing here tonight, which is to share with you guys what we learned as a form of way of saying thank you. Now, let's get started with our topic tonight, which is improving porcelain veneers. I've had quite a bit of chatting to our referring dentists and colleagues, and quite often this particular topic comes up because, number one, this topic, this treatment modality is becoming more and more popular. Patients certainly seeks it. There's a lot of social media advertisements, of course. We've all seen that. But despite how common this treatment modality is, but it often attracts a lot of anxiety for clinicians doing these sort of treatments for a variety of reasons. Sometimes clinically, they can be very clinically challenging. There's many steps involved, very aesthetically demanding, and often the type of patients that you treat could be quite demanding from one way or another. So when you add everything together, and of course, that can attract a fair high level of anxiety. So I thought, why don't we tackle this topic, break it down into the entire sequence, starting from planning and indications and risk, right up to mock-up, prep, impression, provisionalisation, and finally cementation. Let's go through each of the entire treatment step and hoping to improve predictability and to reduce your risk level. And we know that we're jumping, of course, straight, into the topic of porcelain veneers. But we know that there's a lot of different options, and as anything else, we have to, of course, assess each individual case carefully, and then discuss all the options with the patient first. If I may quickly just go through them, just so that we can then get on to the topic at hand. First and foremost, what about no treatment? Because we all know that, particularly with porcelain veneers or a lot of the veneer type of treatments, it's largely aesthetically driven. Therefore, it could be largely elective. And especially if the patient's pre-existing dentition is very healthy and that may already look very, very good, then it better be a very compelling reason, I think, or you better be sure that your finishing product is nothing but spectacular. Otherwise, I think we may have some problems on our hands. So no option, of course, is always one of the first options to discuss with your patient. There are some teeth that are endodontically treated, and patients are not very happy with the discoloration of the teeth, and perhaps using a non-vital or internal bleaching could be a completely appropriate option. And here, after internal bleaching of the two central incisors, the patient was already more than happy enough with the color that we achieved. He's got these slightly older composites in the incisal areas, so we just did a minor repair, and that was it. And that was more than enough for the patient to be satisfied with. There are times that perhaps just external vital bleaching is more than adequate to improve the shade without doing too much else. Sometimes, because of spacing or teeth being in a malaligned position, perhaps just orthodontic treatment might be adequate. I know many of our colleagues now are offering orthodontic treatments, particularly with clear aligners, with 3, 4, half a dozen aligners. Often that can go a long way in terms of whether space closure or rotation of teeth. So perhaps orthodontic treatment is a very good option without needing to cut any teeth down. Then, of course, composite resin veneers. I know many of our general dental colleagues, your composites are way better than even mine. So, if I could do composite as well as some of you guys, maybe I would not be doing so many porcelain veneers. But look, if you have the skills to do these things at a very high level and it's very conservative to the patient, why not? That's a terrific option to consider. But because of the limitation of the time that we have tonight, we're only going to focus in depth in porcelain veneers, and we're not going to really touch on all these other treatment modalities. So my apologies if you thought we were going to cover all aesthetic options. We simply just don't have the time to do that tonight. In some cases, perhaps porcelain veneers is not the right type of treatment modality. In the severely worn dentition, for the patient with severe bruxism, where there's not much tooth structure left, porcelain veneers are perhaps even contraindicated sometimes. So maybe in some of these much more aggressive cases, perhaps crowns may be even a better option. So all I'm saying here is that there's a large number of options. I think we should go over with the patient which is feasible, which is rational, and then document it well before we're just going to jump straight to porcelain veneers. And all the cases that we're showing you guys tonight, we're not going to go through the treatment planning of every single step, all the different options for every single patient, because time just does not allow for us to do that. So it may appear that all cases tonight we just went straight into porcelain veneers, but that's far from the truth. So every patient we go through a very comprehensive process discussing all the options, and just purely for time-saving purposes, we're jumping directly into the topic of porcelain veneers. Now, we know that treating patient selection or case selection is of extreme importance. And so we would like to start off first by looking at perhaps what are some of the common indications for porcelain veneers and what are some of the main risk factors, because there's nothing worse than doing so-called the right treatment but for the wrong patient or for the wrong situation. Then nothing really works. So first, Ghada, could you tell us more about that?
Thank you, Ben. Well, I believe that before starting any treatment for any patient, we need to determine whether that patient is suitable or not for treatment, especially for porcelain veneers, because they're more like an elective procedure. Most commonly, they are indicated to improve dental aesthetics and smile. They're minimalistic. Some of them do require very minimal preps and some require no preps. However, once the veneer is cemented, the process becomes irreversible. So if the outcome is not up to the expectation of the patient, if the veneer sustain early failures, then the only management would be to remove the veneer, which could be daunting, could be frustrating for the clinician, could be frustrating for the patient, and also it would require removal of extra amount of tooth structure. So it's always ideal to determine if the case is suitable or not before starting a treatment. So commonly veneers are indicated when we're managing spacing and gaps, for example, diastemas, improving on shape, improving on size, like managing peg-shaped laterals. Also to replace old restorations, whether these restorations were direct, like composite resin, or indirect, like old failing veneers. However, the goal would be the same for each case presenting to our practice, is to improve patient aesthetics with the least amount of tooth reduction. Sometimes patients would present with multiple issues, not just one problem. These issues altogether, they represent a general aesthetic disharmony, like those two photos. But at the end, we have the same goal in mind, is to improve patients' aesthetics, to improve their smile, their confidence, but with the least amount of tooth reduction. In terms of contraindications, I prefer to talk about that as risk factors, because some of them are not absolute. Once the factor or the condition is managed, then it does not represent a risk for a veneer failure anymore. Like, for example, patients who require orthodontics, like in this case, a deep bite. Once the deep bite is corrected and once the anterior loading is managed, then there is no problem in proceeding with treatment of porcelain veneers to improve the smile. Having said that, in some of the cases, the deep bite has resulted in traumatic occlusion and stripping the palatal enamel. In such a case, the buccal veneers are not suitable in their own, and possibly maybe palatal rehabilitation would be also required in these cases. In cases where patients have severe parafunction, they've lost a lot of amount of tooth structure, those patients, they manage to destroy and break the strongest part of the body, which is the enamel and the teeth, so there's no guarantee that veneers will survive in such a harsh oral environment. Root canal treated teeth per se that do not represent a contraindication or a risk to veneers in terms of, because before we used to think that root canal treated teeth are brittle. However, a lot of recent evidence showing that they have the same moisture content and physical properties as vital teeth. So it depends on the structural integrity of the tooth. So if the tooth has a small access cavity, small restorations, so these teeth can be managed by veneers, for example, this case here. However, we need to be aware of the risk of discoloration under the veneer. So we let the patient to be aware that there's a possibility of discoloration over time, and because veneers are thin and translucent, the dark shade of the tooth will show through the veneer. So maybe have in mind a plan if this happens in the future, maybe by internal bleaching, or patient would be expecting maybe a second round of restorative treatment. So for the topic with diffuse discoloration, is going to be discussed a little bit more in details, a little bit forward in the presentation. But for the time being, such discoloration that is really severe, it is impossible to be managed by a thin and translucent veneer. So veneers can manage minor discoloration, but when it comes to discolorations that are resistant to, for example, bleaching, you could not improve on the color by bleaching, that the veneer, it would not be possible for the veneer to manage such discoloration. In cases where we've got heavily restored teeth, we all know that veneer derives its strength from the durable and long-term bond with enamel. So if there's not much enamel left, we cannot expect from the veneer to survive for a long time. And also similar in cases when we want to increase the occlusal vertical dimension by more than 2 millimeter, in case the veneer is not supported by underlying tooth structure, and more than 2 millimeter of the veneer is hanging, the veneer would be more liable to fractures, complications, cracking because of its brittle nature. And when patients present with perio, or they're presenting with caries, of course we need to improve on their hygiene, improve on plaque control, make sure that the patients are compliant before progressing into veneer treatments. The last factor I want to talk about, and it's actually not the least, it's an important and major factor in determining whether patients are suitable or not, especially for aesthetic treatments, if their underlying mental and psychological health. So if patients have like severe depression, they've got body dysmorphic disorders, they've got unrealistic expectations. The issue with those patients is that in spite of their in spite of the condition, whether the condition is simple or it was complex, and regardless of the outcome of treatment, even if you provided the best treatment in terms of function and aesthetics, these patients could still be upset at the end, could still be angry. They can cause a lot of drama, a lot of loss of sleep, and sometimes it's wise if we identify that the patient is one of those cases, to refrain from providing aesthetic treatments, especially veneers, because they're irreversible. So there appears to be several risk factors that we need to be aware of when we choose to provide patients with veneers. Thanks, Ben.
Absolutely. Thank you so much, Ghada. I completely agree that a lot of the risk factors that you mentioned, they're not necessarily absolute contraindications, but they're just risk factors.
Yeah.
And of course, the more number of risk factors, then obviously the higher the risk. It doesn't mean that you can't do porcelain veneers per se, but please do exercise discretion. One of the viewers asked the question, I mean, since we're talking about severe bruxism, they said that, well, what if they do not agree to wear their splint? Perhaps we have a number of patients that have a number of reasons that they can't tolerate splint. Some of them just simply don't want to. Yes, some of them says it gags, or there's some degree of intolerance. How do you go about managing that under the assumption that they still are really interested in veneers, but you're worried that bruxism is a significant risk factor?
Well, first of all, patient has to take responsibility of the treatment as
sure.
well. So they need to understand if they're not wearing their splint, they're not managing their parafunction during the day, then they're more liable to fractures, more liable to maintenance issues, repair. So they have to have this understanding. Also, we're going to talk about the consent and writing all that down. Plus, also, we can try with managing the occlusion. So the way we adjust the teeth, we plan the occlusion in a way we reduce loading. But in cases where the patient is a severe bruxer and patients they decline using a splint, in these cases, and I believe if I provide a veneer, it will definitely break. In this case, I do not believe that I would be providing this treatment, because at the end of the day, when I provide the treatment, it's my responsibility. So it's case-by-case basis, depending on level of parafunction, patient compliance, occlusion. There's so many factors that we need to put in consideration before saying yes to veneer treatment or treatment in general, or no, because sometimes you got the beautiful clinical case,
yes,
but not the personality, we still can't provide the treatment.
Absolutely. It comes with a lot of risk, basically. Yeah, I agree. I mean, in theory, you could consider maybe some other options. It may be including, say, Botox therapy. You know, there are some other ways of managing parafunction or bruxism, but that occlusal splint still may be extremely important, I think, in the long-term maintenance and for the longevity of that veneer. You've also mentioned in internal bleaching, or sorry, I beg your pardon, I mentioned internal bleaching. One of the audience asked, perhaps the panel could help out, is they tried internal bleaching, but unfortunately the tooth relapsed again. Mm-hmm. So what do you do here? Do you keep on just whitening the tooth internally again and again, or how would you go about managing that?
I think it's a common problem with the internal bleaching with endodontically treated teeth. You expect some relapse down the track, and quite often if the treatment carried out, I think one of the slides that Ghada showed with the porcelain veneer, you can see the grayness shining through. Mm. And initially, I'm assuming in the early phase of treatment that wasn't the case. So you could reattempt the internal bleaching for sure. Or the alternate will be, if this is an ongoing problem, converting to a crown, which have a low translucency ingot, and that will prevent the color going through the thin layer of porcelain.
Working with endodontist, Mehdi taught me that it also depends on what is the endodontic material that was used. Mm-hmm. For example, back in the day, there was a lot of silver halides as a compound that's used in the endodontic sealer, mm-hmm. and it's that ultimately discolored the teeth. So unless if you're going to change the actual endodontic obturation mm-hmm. and the seal, you're going to remove mm-hmm. all the old stuff, wash everything out, and then new, more modern, endodontic sealers mm-hmm. and obturation materials. Only then can you get a much more stable mm-hmm. result. So I think there's a few numbers to link to, perhaps. What is the cause for that relapse of that discoloration as well? And Ghada, of course, you also touched upon mental health condition. I'm really glad you touched upon that, because there are a lot of, in my opinion, that's more your sort of higher risk patient, or your sort of your red flag type of patients. Not just for veneer treatment, but for treatment of all types of cases, mm-hmm. really. The bigger the case, the bigger the rehab, and of course, I think the alarm bells should go off. Some of you guys, I may have shared this story. This is Andrew. For the ones that you guys already know the story, my apologies of retelling it. But this is one of the biggest mistakes that I've made as a specialist. So this is my first or second year out as a prosthodontist. Back in the day, I still think to myself, I can do anything. Any problem walking through the door, I've got this. And Andrew found us through the internet, which I was very pleased that my website was working at the time. And he wasn't happy with his veneers. According to Andrew, he received these 10 units from the States. And he felt that they were too opaque. It lacked symmetry in some areas. And he wasn't happy with the incisal edge position, as well as the shape of some of the teeth. So when I was assessing his teeth, I could recognize objectively all his concerns. And also, objectively, when I'm looking at the wear pattern of his teeth, the wear is relatively minimal. So there were 10 units from 5 to 5. Eccentric, he even had an anterior open bite. So, all the risks that Ghada previously said in terms of maybe the deep bite, severe parafunction, worn dentition, right? Those things didn't exist. And so I was thinking, I think this is doable. And then during lateral excursion, he's got pretty good canine guidance. So I thought, well, from an objective, technical point of view, I think I can do this. And also Andrew appeared to be a very nice person, well demeaned. But he came with his own choice of ceramist. Mm-hmm. So as in he said, Ben, I found the right ceramist. His name is so-and-so, and I would like you to use this particular ceramist. And at the time I thought, how diligent of you. Oh, that's terrific. Even he found you're a ceramist, and he found a really good ceramist. And this ceramist, although I never worked with previously, but I've heard lots of good things about this person, and I thought, well, this might be a great opportunity to try the ceramist anyway. I didn't think anything of it. There was some other interesting thing that happened as well, which again we didn't really understood why, but there was some conflicts in names. So, for example, for the first time when he contacted us, he would use the name Jason, for example, which later on, when he filled out his new patient form, it became Andrew. So we thought, okay, we may have made an admin error. And then later on, when he paid in terms of the credit card, it was a different name again. There was every time was a slight different variation. Again, we saw it, but I didn't know how to interpret it.
Are you sure it wasn't a twin?
That's right, his twin brother. So anyway, I proceeded, with caution. So first we did we did a little, this was more than 10 years ago. So digital smile design was a little bit different back then. But we did some sort of digital simulation to show the teeth shape, incisor edge position, just to confirm what he wanted, and then that was converted to a wax up, extremely good wax up. Then I removed the veneers, then using a putty key, right? I put these provisionals right in his mouth, and he was very happy with the shape. So now comes the ceramic work, beautiful ceramic work. I couldn't fault it at all. The marginal fit was phenomenal. And the shade was exactly as what he picked. I think he picked it was a 1M2 or 2M1. I can't really remember exactly, but when you get on the shade guide, the shade tab, it looked exactly like it. Long story short, he wasn't quite happy when I tried the veneers in. 6 try-ins later. So each try-in took about an afternoon, right? You got to numb him up, you got to remove 10 units, put the veneers on, didn't like the shade, take photographs, take it off, provisionalize again, 10 units, polish, right? It takes some time. So 6 try-ins later, it was just before Christmas, and he said, that's it, Ben, you got it, we got it. And I was so excited, thinking that, yes, finally, I did it. I tried in using translucent temporary cement, or try-in paste, and then I cemented using translucent definitive, liqueur only resin, just to make sure that the color is stable. Once I finished everything, I was really proud of myself. And here's when I gave Andrew, I think that's his name, a mirror, thinking that I was going to get a glowing review. And then the words that came out of his mouth, I still remember to this very day. He said, "It's wrong. It's wrong. It's all wrong." And that's exactly what he said. And so over the next course of a month and a half or so, this really nice, easygoing, easy to deal with, what seems to be rational and reasonable patient turned into something that it was just completely different. The language all of a sudden became extremely inflammatory. There was a lot of anger, threatening, legal threatening. All these things started to pile on because he wanted me to cut all of them off, pay the ceramist again, 10 units, and then just to do it again. Although he gave me clear consent that he was happy. And then I started to reflect, later on, if I were to do this case again, clinically, would I have done anything differently? I honestly couldn't think of one thing that, clinically speaking, I would have done anything differently. But he wasn't happy at all. That feeling where your heart just sank from your chest down somewhere around your pelvic region, that stayed with me for weeks. I couldn't sleep for a few nights because of he was threatening legal actions. And I was thinking to myself, oh my God, what am I going to do?
I think it stayed with you for years.
Yeah,
Now.
it's the scar. You can see the scar, right? It's obvious. So I learned very quickly, and eventually I gave him a full refund, just to pay him to go away, basically. Yeah, or pay for the problem to go away. After consulting with a number of my mentors, and also my medical, legal, professional indemnity insurance people. But I learned that clinical assessment, of course, is very important, but we also have to assess the personality of the patient. That's really important. There are a large number of personality traits. Now, I'm not a psychologist, I'm not a psychiatrist. In fact, I never had one even lecture on psychological assessment. I have no idea about any of this. But all of these is based on just a pure history of learning, learning on the job. That I think our patient, if they exhibiting any of these personality traits that is going to be difficult, again, I'm not saying that we shouldn't treat them, but I am saying that you should take caution, especially if you're doing big treatments that are expensive. It's going to be time consuming. A lot of things could potentially go wrong. Well, then you need to have a very reasonable, understanding type of patient. Expectation is something that's really hard to assess as well. We do have to gauge somehow, what exactly does the patient want, and Zoe is going to help us, talk about how to doing some good mock-ups to work out precisely what the patient want. But then we also have to, once you assess the patient in terms of clinically, a lot of risk factors that Ghada said, I think, the personality factors, which, Agnes is going to talk a little bit as well. Then when you have all the risks involved, you also have to think about, do you have the right ceramist? Because most of us don't sit there and make our own veneers. I know some people may, but the large majority of us don't. So can your ceramist do it? Can the rest of your dental team do it? Can the entire team able to, including yourself, be able to satisfy or meet the patient's expectation? And if you couldn't, somewhere that you think you may struggle with that, then you have to, I think, really ask yourself twice before proceeding with that sort of treatment. So yeah, take a lot of caution when proceeding ahead. Talking about medical legally, Agnes, I know you spend a lot of time talking to your patients for very good reasons, right?
Is this a complaint?
Not at all. Hey, you have one of the highest patient satisfactions, right, out of all of us. What are some of the medical legal aspects, do you think, that we should be aware of while consulting our patient and get that consent?
Thanks, Ben. So with porcelain veneers, it's certainly a very unique type of service modality that we provide as dentists, because yes, there are occasions where it is part of a oral health treatment, but there will be also situations where Ben had outlined is completely purely cosmetically driven. So when it comes down to something that is just aesthetically driven, it can be difficult to define because, we've all, I guess we may not have all, but I've certainly experienced some patients coming in, they want their teeth to improve in form and shape and color and look better, but they don't exactly know how. And then they will say to you, well, you're the expert. So whatever you do, like you should know what I want. And I look at them and go, I don't know what you want. And it's important for us all to understand we all have what we call internal bias. What we think a nice smile should look like. But indeed, what can your smile actually look like? And what does it look like right now? But also, it's easy for us to also, talk about a lot and understand, there's external biases. So these are your social media, particular model, the distortion of the Instagram camera. But alongside with all of that, I think it's important to stress that as clinicians, and many of us are, very aspiring clinicians who want to do really beautiful work that we also see on the dental forums in our own professional media platform, what we think ideal aesthetics should look like. So we also come in with a set of our own internal bias as an operator bias. So now marrying up all of that, right? In the end of the day, the fundamental, I feel, in the medical legal aspect, as we treat these porcelain veneers, is very critically being able to identify that as a service provider, are we providing the veneer option as part of the overall oral health care plan, where it comes with a diagnosis, and this is one of our treatment options, and we go through our classic problem list and so forth, and this indeed actually is something that fits the criteria of necessary and appropriate for the patient. We now take the flag of your clinical dental provider to provide this treatment. But in the scenario where dentists are helping patients to purely improve their cosmetic, now even that has two categories, because there are those categories where their cosmetic is overall from a health perspective compromised, whether it is like genetical presentation, whether it's managed previous erosion that is now stable and ready to have some consideration cosmetically, or purely you have the other category of patients that you've kind of dabbled on, where there's actually no other etiological background surrounding their oral health issues, and the spectrum of the aesthetic need is not actually that obvious to the peer, whether this is your public peer or your dental colleague peer review. And now you are dealing with a patient, just you and the patient. So when you are faced with a scenario and you choose to deliver that result, like you said, better be damn good, because the public and your peer will carry the opinion that you have to deliver your work to a state where it is clinically sound and manageable, and the long-term maintenance, or what about issues of particular fractures, so forth, become a lot more gray area of this warranty. Now, in the end of the day, it does come down to good notes, good record, then you have something to fall back on. But if you don't have any particular record of planning all of these together with your patient, you're really caught. And sometimes, like Ben's case, despite the best of records, when the patient actually becomes in a position where they're no longer satisfied and they're upset, it's just really between your version and their version, and how would you like to see that through. So in the coming segment, Zoe and Ghada will go through the intraoral mock-up, and Ghada's gone through some actual case selections. And but globally, research has shown us that if we get our patient involved with the let's say the diagnostic process of what are these subjective criteria that they are trying to express, can you actually objectively paraphrase what are the correction parameters? And if you are using these days any digital AI generated tool, which is amazing, and I think they give a very good visual, they have a very fast response and impact. However, as a clinician, I think you always have to take a little bit more reserved response to their fast response, and actually factor in, go a little bit deeper of how much detail they are looking at in perceiving that photo or perceiving that mock-up. And what I mean by go a bit deeper is then you can determine whether they are a high detail person or they're not as high detail. They're more like, just looking at the overall visual. And another parameter is whether once they can see something is improved, their visual or their attention now switch to another, and they're constantly chasing some other imperfection to correct. So these are the things that I look for and I list out, and this is just in the consultation aspect. So we do have to remember on those parameters as we take down the record, so that at any time at all, if you do not feel that you're in sync with your patient, whether it's even just an understanding phase at the beginning, I do not feel that, like, I totally agree with you in that, patients with certain mental health vulnerabilities, there is a red flag in how we care for them. Especially proceed with caution and only do what's appropriate and necessary, especially if their vulnerability or trauma is related to past dental issues, whether it's procedure or just their dental health. However, sometimes if it is just to do with a little bit of self-confidence, it always is quite uplifting just to let them know you think they look beautiful as they are without treatment. To really just get an honest platform of really trying to decipher whether this is something we can help or they need greater help from others. So one of the aspects that I think we need to know is, if you're also unable to finalize things with the mock-up, it is okay to have what we call a mid-treatment termination clause. And I think this is important in drafting your initial consult in terms of a workflow, to let the patient know, well, there's this consultation process, there will be some design process, and then before we even pick up a bird to treat and manage, and there will be some interim professional to fine-tune things. And if along any of the way that you are not in agreement, it's important to be able to have a termination comfort zone for both parties. And as part of this mid-treatment termination clause, I will also bring about this, what we call a laboratory consent, or a consent before we actually make the definitive prosthesis. Now, this is where I feel that, we can embrace all our dental knowledge and the dental aesthetics that we learned into the discussion with the patient. So let's take this for example. Patients quite happy with the professional of the upper arch. We are on the right track. They're happy with their speech and the anterior relationship. So this is a place now where we can actually use our dental jargons and our trained eyes in looking at dental aesthetic and point out, the midline is off the center of the face, but this is the midline where we are able to give you symmetry in dental proportions on either side. Is this something that bothers you? No, it doesn't bother me. Put it down. We then look, the lateral incisors on either side still have a bit of disproportion. While some people might like, of all the teeth, the lateral incisors can be one to be more playful with. But in this scenario, we do want to make them a little bit more balanced. Note that down. We have some black triangles. Does that bother the patient? If we were to fill them in, we will change the cervical profile and the look and the width of these teeth. Is that something that they would be happy with? Oh, yes, because I do find them flare up a bit and they quite flatten the top half of the teeth. Now that you pointed out, these are the things that you can talk to the patient about. And lastly, the occlusal plane, we're more or less on the right track, but the 1.5 hangs a bit lower. Let's note it down. This is something that we can improve on. So then, as we're able to document these, critique together, it demonstrates that, your professionalism in going through the design parameters. Patient also feels that they have been involved along the process. They feel like they've contributed to the design. And then, in the final result, we can see that those are the aspects from what we learn on how we can improve, has indeed been able to be translated in the definitive try-in. So I think this is where we do have to open our hearts and mind a little bit from what we have learned. Also try to listen from our patient, but also I feel be very comfortable to say no if this is purely on design and is really a treatment that is not necessary, not really appropriate, and now you're really on the platform of delivering a service more than a health provider, although at the end of the delivery you will be viewed as a health provider.
Yeah.
I think those cases are the ones that you have to be particularly careful about.
And how do you go about saying to the patient that, ooh, you know what, I don't think I'm the right person for treatment? Because that is one of the questions from the audience.
It's very interesting because I do have a particular case in mind that I remember very well. The patient had, have a mannerism where she's very specific with what she was after. And she wanted a very specifically high level of aesthetic result. But it was pretty much just that. She couldn't really voice what exactly are the result or the types of veneer. It wasn't, your American style, or like there was no actual tangible things that I could correlate. And although she does have some restorations that needs to be replaced or can be considered replaced, however, I did feel that I couldn't do it together with meeting all her aesthetic demand. So I respectfully let her know that while I look at aesthetics, I do personally tend to be a natural aesthetics person. So I tend to only deliver natural aesthetics results. And then she goes, that's not exactly what I was after. And then I said, yeah, I don't think that's what you're after as well. So I think there will be much more better clinicians, because if you take on an artistic persona, artists have different styles. And I'm quite comfortable in admitting that I can't, I most of the time I have a bias. I tend to not deliver that style. And having said that, she was actually very happy, and I think she appreciated me being quite honest with her. So yeah.
So at the end of the day, it's not you, it's me. That's the problem.
Well, I think it's just we didn't come to an agreement, and if that agreement can't be there from the beginning, then it's hard. Yeah. Yeah. So I think at this point, Zoe is going to take us through different type of scenarios in doing intraoral mock-ups and the design process.
Thank you. Thanks, Agnes. I think thank you for covering all that documentation and the planning aspect of the treatment. I think that's quite important. So what we'll do is talk about designing a mock-up for the treatment. So one of the most important, I think I'll go back. So generating a mock-up, it is one of the most important part of starting your veneer planning case. First of all, you can able to assess the aesthetic function and phonetics for the patient, and also have a guide on whether that person is person expectation within reach. Are we able to deliver the treatment that the person want to have the veneer treatment for? So this is the time where we can suss out which case we can carry on and which case we have to terminate right there and then in our treatment phase. So there are four main types of generating a mock-up. The first one is intraoral mock-up. We can have a analog diagnostic wax-up, perhaps a digital smile design or a digital wax-up. So if we're looking at intraoral mock-up, this is an easy, straightforward procedure. The patient might be during the consultation appointment, sitting in the chair, and they're interested into having a look at what a veneer treatment might look like. So this is just applying a composite resin onto the teeth. Remember not to bond that composite. It's just light cure for about 8 to 10 seconds. So it's just a snap set. And we give the patient a mirror. They have a look at what that mock-up might look like in the chair. So for instance, this case here that the patient presented at consultation wanting 6 veneers, porcelain veneers, and she denied any orthodontic intervention at that time. So with an intraoral mock-up, just by applying 2 direct composite onto 1-1 and 2-1 during that consultation visit, she actually came to a realization that she's more than happy with the aesthetics of her teeth, and that's all she wanted, is just having the 2 front teeth treated, and that was the aesthetic outcome she was after. So there, the veneers were made, mented, and this is the final outcome. So that intraoral mock-up is very easy, simple to carry out. Anyone can do it. Just spend some more extra time in the chair, especially if there's a 1 or 2 teeth treatment. However, if there is a lot of teeth that needs to be treated, then the other option of doing it is going through a diagnostic wax-up. Now, for the diagnostic wax-up, remember that we always need to have some extraoral photos, intraoral photos, study models, and also assess at that appointment where the incisal edge position needs to go, where the midline is, how much correction. So just we have to have some sort of an idea or where we'd like to deliver the final smile for that patient. And then we can design our diagnostic wax-up. So we need a bit of planning, a lot more time before the next patient appointment. So if we are to when the patient comes back after we have generated our diagnostic mock-up, then we using the putty keys, some self-curing acrylic resin. You can use that putty key to apply the mock-up in the mouth and show the patient what are you proposing for the final smile or smile design. And any correction that is needed, you can come back and modify it onto the diagnostic wax-up. So this case here, we can see the patient wanting some diastema closure. So not a major changes to the smile, but she wasn't quite happy with the diastema. So following a simple diagnostic wax-up, that was showed as a mock-up in the mouth, and then a provisional restorations, provisional veneers were made. Then you can transform that into the final results, and you can see there's quite a resemblance between your diagnostic wax-up and the definitive veneer restoration. Now we've got to also keep in mind that there are some sort of ideal ratios and tooth shape and tooth form that we have to keep to have some sort of knowledge about when we design our restorative designs, so whether it's the diagnostic wax-up or proportions of the teeth. So what's called the golden proportion, which is the ratio between the central, lateral, and canine, where the central might have 1.6, where the ratio to the lateral is 1, and then the canine is 0.6. The contact areas in the between the centrals is about 50% of the length of the central incisor, whereas for the between the lateral and the incisor is about 40%, and at the canine is about 30%. So these are golden proportions that we need to consider. The other part that we have to look into is the width-length ratio of teeth. So there is a variation in the dental aesthetics, and these variation depending on the facial form and the variation with an individual, so whether brachyfacial, dolichofacial, things like that. So there we expect the central incisor to vary in length, somewhere between 10 to 11.2 millimeters, and in width, ranging between 8.7 to 9.3 millimeters. So an overall ratio of width to length ratio might be about 80% for a central incisor. And then if we come to the lateral incisor, so that lateral incisor will form 78% of the central incisor width, and then of the canine is 87% of the width of the upper canine, whereas the canine form about 90% of the width of the incisor. So these dimensions are quite handy when a patient walks through the door and they're looking to redesign their smile. So we've got this case here where that young lady presented. She's not quite happy with her smile, that something is not quite right about the teeth shape, form. So if we look at that, we can pick up different issues. For example, the excess gingival display between 1.2 to 2.2, the uneven gingival zenith, and also looking at the width and length ratio of the central incisors. They look a bit more squarish form. The laterals, they're too wide and too broad. So when we come to design this, we have to talk not just about the width-length ratio, but also improving the gingival contours for that patient to enable us to achieve a better aesthetic outcome for her. So by performing a simple gingival recontouring and having a diagnostic wax-up, so you can carry it into the mouth as a provisional veneers on 1.2 to 2.2. Now, the idea of putting the veneers at the same time as the gingival contouring is to help the gum heal into that shape and help form the position of the gingival tissues at that appointment. And being a provisional nature for the veneers, then we can come back and bring the patient after healing to carry out the definitive veneers, where the lab has made us 4 incisor veneers, and that's the final results for the patient. So 4 porcelain veneers on 1.2 to 2.2, and then a bit of composite addition to 1.3 and 2.3 just to level up the incisal plane, and that has changed the aesthetic, provided the patient with a better aesthetic outcome. Now, the other form of providing a mock-up is the digital mock-up. Now, with digital mock-up, remember, we need some extraoral photos for the patient, and we need to have a scanner. So we need an intraoral scans. There's a different software that we can use for the mock-up, and I'll discuss them throughout the presentation. But in the early days, we had the digital smile design. So this is the early form of the smile design, where you've got the intraoral photos, extraoral photos, and then changing the contour of the shape of the teeth manually to kind of mimic a nicer smile for the patient. And then the lab will measure the width and length of this proposed shape of the tooth, and then they do a manual wax up, and from that wax up you can generate a snap-on kind of indirect restoration, like made out of acrylic resin, and then bring the patient back, try that in the mouth, and then change any sort of modify any aesthetic parameters that you'd like to modify. So it's quite a long process, but I think that smile design have moved on to now there's a digital AI smile design where you also take the intraoral scans, the extraoral photos, and it's kind of they've got quite an advancement in technology where they pick different libraries of tooth form, tooth shape, superimpose that onto the patient actual teeth, and then from that you can actually generate and print. So export this into a printed model and use that to carry out your mock-up intraorally. So once you've taken your model, then you use your putty keys again and generate a intraoral mock-up for the patient. So with that, you can also sort of promote that treatment to the patient. So give them a realistic tooth color, shape, superimpose on their face, so they can assess it. So this communicate quite well in terms of veneer treatment. Another software that you can use for a smile design is 3Shape design. Again, they've got a vast library of assessing the facial pattern of the patient, picking up the right library design of the teeth, and then you can also change those teeth, so move them around slightly, increase the length, change the form, and show the patient the before and after of this mock-up. There's another software, it's ExoCAD. Also, you can do model makers, smile design for orthodontics as well. So all of these sort of a blender where you can replace missing teeth, build up the shape of the teeth with a wax up, and then generate a model from that. So you've got the before and after. So all these ways of generating a mock-up for the patient, generating a guide, whether it's radiographic, surgical, or a template for a mock-up. Or the simple old way of handing the case to the lab, and they can help us design a restoration, 3D restorations on the teeth, and give and generate a model for us as well, where we will try intraorally. So this is one of the very old cases for digital smile design, where the patient presented unhappy with the smile. He's unhappy with the uneven incisal position, asymmetry between the 1-2 and the 2-2, and the opaque color of the restorations. Now, looking intraorally, there's a lot of issues that stands out there, and in particular, that lateral in the 1-2 position is actually a canine that has been mesialized into a lateral position, and the tooth in the 1-4 and the 1-3 position is a missing tooth. So that's a pontic. Now, there's a lot of issues that we worry about in a case like that, and try to talk about alternate treatment, whether we can distalize the canine again and then replace the lateral with a pontic. But the patient had enough of treatment. He did not want any further correction to the tooth position. So this is where it stands from the occlusal view, with the size of the 1-2 and 1-3 quite dissimilar. So showing the patient with that digital smile design, just a sketch on the tooth, the limitation of this case. This is not going to be a case where we will be able to achieve a nice outcome, just because of the disproportion of the 1-2 to the 2-2, the gingival zenith, the embrasure level. There's quite a lot of discrepancy, but telling the patient right there and then, this is what we can achieve for you. It's not going to be an ideal symmetry on both sides, but that will give the patient an opportunity to either decline treatment or accept going forward, knowing the limitation of the treatment. So ended up having 3 veneers and that cantilever bridge, and that's the aesthetic outcome. And he was quite satisfied, because knowing what he was expecting right from the beginning.
Absolutely. Mm-hmm. Well, thank you so much for covering all the different options there. Zoe, very, very, very helpful. Quite often, I find I sometimes even using more than one, sometimes during certain complex cases, just to make sure the patient is happy.
Yes.
It's an interesting question. I don't know the answer to this. I was hoping that the panel may share some light. Is there an item number that we use during this mock-up, the composite mock-ups that we put on patients? I know there's item numbers for for photos and models and wax-ups, but the actual procedure, the clinical procedure to transfer that information intraorally, because that's the more time-consuming bit often, right? Is there an item number for that, or?
Well, I normally put it as a diagnostic wax up. I wouldn't put it as a restoration as such, because it's coming off, like it's getting flicked off right at the end of the appointment.
Exactly. Yeah.
So just a wax up planning phase, part of the consultation. You're kind of promoting a treatment that, hoping that the patient will accept, and and offering them something that they may or may not that might achieve their expectations, and they may decide to go ahead with treatment. So it's just part of your diagnostic. Not everything will be charged for at that stage, I believe.
Yeah, and I think I certainly agree with you. But a lot of the times, after we actually do the diagnostic mock-up, we would take clinical photographs of all the different extraoral views, and sometimes intraoral. And most definitely, it's almost 95% of the time after my diagnostic wax up directly in the mouth, I would take a model. Now, whether this is an alginate model or a scan, these are details, things that you can either print off a model that you can work on, or you were only able to establish certain reference point, and that you actually need to send it to your laboratory to order the actual diagnostic wax up. So therefore, I would be utilizing numbers such as 071 if this is to be a study model of some sort. 072, 073 would be your clinical photography. 074 would be if you're actually generating a subsequent diagnostic wax-up to be followed according to your mock-up. But certainly your extended consultation time, 015, because alongside this would be your notation of all the parameters that you discuss and validate, and should be recorded as well.
Absolutely. Thank you so much for sending in your questions. Keep them coming. There's a number of questions on bruxism. How do you prove the state and bruxism? How do you manage them, etc., etc. We just simply, because of the limitation of time, we won't go into detail in answering some of those questions, because we've covered them in some of our previous webinars on the management of the worn dentition. So check out that. There's some other questions regarding to occlusion. What type of ideal occlusion should we finish the cases in terms of anterior and lateral guidance? So again, excellent question, but we just don't have a lot of time to go into it, because sometimes that takes easily another 5-10 minutes of discussion just on that question alone. So please check out our previous webinar, which is on improving occlusal management, I believe is the title.
But I think later on, as Ghada go through some preparation design, different types of veneer preparation, these are surrogate information that you can consider in terms of looking at the resistance and retention form that the preparation, the restorative design of the veneer would take. But of course, applying into bruxes, then other consideration takes place.
Absolutely. So while on that topic, so once we finish the mock-up, we have a reasonable idea that that's where our end goal is going to be, and the patient's relatively happy. We're about to put bird to teeth. So Ghada, can you tell us about how do we go about preparing teeth, and what are the different types, and how deep do we cut teeth?
Thanks, Ben, and also thanks, Zoe, for the detailed and comprehensive discussion on the wax-ups and mock-ups, digital and analog, because this is really the base of the next step, which is preparing the teeth. Because from before, we need to understand and to make sure how much are we going to prepare, how much of enamel are we leaving. So ideally, we should be prepared the least amount of tooth structure, leaving at least 50 to 70% of enamel for bonding. And at the time of the preparation, before we touch the burr, we need to do the mock-up again. That is after the patient have approved it, of course, using a temporary crown material. And then we pick up the burr and the handpiece. We use a depth cutting burr to determine the exact thickness of the porcelain veneer we're planning. And because we already done the mock-up, we knew that this is an additive approach. will be adding to the tooth more than subtracting to give the patient a full smile. So we already knew from before that we have most of our preparation in enamel, or the margins are in enamel, and this is a perfect case for porcelain veneers. Now, coming back to the topic of discolored teeth, how much do we prepare? Do we need to do we prepare the same as conventional cases? Do we prepare a little bit more? And if you're going to prepare more, then how much more? So as a general rule, and that's not actually my rule, this is Ed McLaren's rule. He's a professor. So he's a prosthodontist. He did thousands of veneers. He's also a ceramist. He published on ceramics, shades, photography. And as a general rule, especially for feldspathic veneers, if you want to change the shade of the tooth to a lighter shade, we need to cut, we have a space of at least 0.3 millimeter of reduction. And for each subsequent lighter shade, we need 0.2 millimeter for each subsequent shade. So for example, here, if we have a tooth of the A3.5, we want to change the shade to A1. This is the 3 shades in between. So in that case, we would need around 0.7 millimeter of reduction. If we apply that rule to the severe discolored teeth, like for example, that tooth, which corresponds to maybe the first shade from the right, because it's severe discoloration. If you want to change that tooth to be, for example, similar to the first 2 shades on the left, then we would need around 1.4 to 1.6 millimeter of reduction, because this is around 7 to 8 millimeter lighter shades. Now, is that really true? Do we need that much amount of reduction? Well, this is a study that was done many years ago in 2014 by a Japanese lab technician. And the results of that study are actually in line with that general rule. So what they did was a bit comprehensive, intense. They did they made lots and lots of resin dyes that correspond to different shades of the teeth, ranging between normal shades to minor discoloration, to moderate and severe discoloration. And then they made a lot of ceramic copings of different thicknesses and different translucencies, ranging between high translucency to moderate opacity to high opacity copings. And then they measured which copings managed to block the discoloration and also how much teeth reduction was required. So for the moderate discoloration, they found that the high translucency copings that had the thickness of 0.4 millimeter managed to block moderate discoloration. However, the amount of reduction was a little bit more than the conventional, was around 1 millimeter. And let me share with you this case because it will explain why we know that why we need that extra bit of reduction. So looking at the 2-1, which was vital, by the way, so we couldn't do internal bleaching because patient preferred not to have root canal treatment. And looking at the preparation, we can see that the tooth is a little bit more prepared as compared to the conventional preparation I showed earlier. And that is for a very good reason, because we needed lots of space to make a coping, to put a few or multiple porcelain layers with stains to manage to block the discoloration. So this is after the cementation, and we can see that the outcome is pretty reasonable because the patient's natural teeth was more white, more bright, more lighter as compared to the 2-1. That's why we needed the extra bit of space to add more layers, have a bit of an opaque coping to manage block the dark color of the teeth. Of the tooth. Now, what about severe discoloration or moderate discoloration? They found out that the moderate opacity coping with the coping that managed to block discoloration, but the amount of reduction required was around 1.4 millimeter, which was actually not suitable, of course, for porcelain veneers. So to prove the point or to explain the point further, Let me share with you that case as well. So this is a patient who comes in with dark crowns from 1-2 to the 2-1, not happy with the dark shade of the crowns. Then when we remove the crowns, now we know why, because the teeth were severely discolored and discoloration was showing through the translucent crowns. The good news was that we didn't need to cut much. It's already been prepared, and this was enough space for the lab technician to do the following, and that's when we would know why the lab technician needs that amount of space. So first, the lab technician made a coping, a medium opacity, of course, with 0.4 millimeter thickness, and then started adding layers, opaque layer, another opaque layer, dentine layer, enamel layer with more stains, opaques, colorants to try and block the discoloration and provide a patient with a result that is very reasonable and very close to the shade of the natural teeth, and the patient was happy with the result. Now, talking about this amount of reduction is really needed when we want to match the shade of the discolored tooth to the remaining natural teeth. But if we have a case where we're doing the full mouth or from 1.5 to the 2.5, this would be different. We might opt to do less reduction and provide an opaque shade for the patient, but I will not go into lots of details with that because my colleague Dr. Johnson-Chou will present it in the next few slides. So in terms of tooth preparation designs, how do we prepare? There's actually a few methods to prepare for a veneer. One method is only to prepare the buccal surface, which is very conservative, very minimalistic. Maybe we could use that. We can use that prep when we want to do minor changes for the shape, for the color. Maybe we want to improve on the surface texture, but however, we're happy generally with the incisal region in terms of shade, in terms of shape, because when we leave the incisal area, we don't have a lot of control in changing the incisal region. Now, second method to prepare a veneer is to cut the buccal plus the incisal, maybe around 1 to 1.5 millimeter. And by doing so, we are allowing the veneer to rest on a second surface. So we have better and more force distribution. Plus, as we're wrapping on the incisal, covering the incisal, the direction of forces change. So rather being oblique with the further preparation or the buccal preparation, they become more vertical. And we all know that ceramics tolerate compression or vertical forces as compared to horizontal or oblique forces. So these sorts of preparations tend to, those veneers who are made to those sorts of preparations tend to have less complications, less fractures, less cracking on the incisor region as compared just covering the buccal surface. Those sort of preparations allow the veneer to be placed through a horizontal path of insertion. So we're placing the veneer from the buccal. So it's easy, it's simple. However, during cementation, it could be a little bit finicky. Because it could shift in the hands of less experienced clinician. So after cementation, we can find that our midline is shifted a little bit, could be canted. Some cases, when we're less experienced, after we finish most of the veneers, we have 1 or 2 veneers remaining. We try to put the canine on and it's not fitting. So we have, before we start cementation, especially when we're starting to place veneer, just make sure that the last 2 veneers are fitting. If they're not, then pick up the burr, adjust the interproximal areas, check the fit, and then cement. Because otherwise, if we try and force it, we could end up with a misfitting veneer. Now, third method of preparing a veneer is to prepare buccal incisal, plus also extend on the palatal surface. But by doing so, we change the path of insertion from horizontal to vertical. And now on the palatal surface, we need to extend maybe 1 to 1.5, making sure that the contact is not on the interface between the veneer and the tooth, because then we can get complications. Ideally, the contact should be on the natural tooth, but if that's not possible, then we could have the contact on the veneer, but never on the interface between the veneer and the tooth. So by covering the palatal surface, we're changing the path of insertion to vertical. Then we have a positive stop. We also have a definitive path of insertion, so it's less likely to shift, easy to put on. However, when we change it to vertical, then it's similar to a crown. So we need to be mindful of minor undercuts of areas of the teeth that could act as a hindrance to the path of insertion. So this type of prep requires a little bit more preparation as compared to just preparing the buccal or the buccal and the incisal. Now, which preparation should we choose? That's the second question. Well, it depends on the case. It's a case-by-case basis. So it depends on if you want to change the shape and the shade of the incisal area. It depends on the occlusion. Can we extend on the palatal without having the contact on the interface between the veneer and the tooth? In some specific cases, maybe a certain method would be of more benefit. Like, for example, if we have teeth that are proclined and we want to move the teeth a little bit backwards to make them a bit retroclined, so, to look a bit better, like that case that Zoe was presenting or showing. So in that case, ideally, we should extend onto the palatal surface, because if we just extend onto the incisal and then we have the veneer moving it a little bit backwards, we end up with a thin area of veneer, but just moving the preparation into the palatal and moving the veneer to overlie and overlap on the palatal, we have a thicker area of the veneer at the incisal area, less liable to fracture. In cases where one preparation or the other would provide similar results, at the end of the day, it depends what the clinician is comfortable doing, the level of experience, also what works best with the hands.
In terms of outcomes studies that's looking at incisal overlap with or without palatal reduction, they're about the same.
Similar, very, very similar, the same actually. But with the studies, so when we provide incisal overlap, regardless we cut the palatal or not, they have better outcomes as compared to just cutting on the buccal surface. But both have similar results. But it depends also on the occlusion. Can you get away with a good occlusion or having the contact natural teeth by extending on the palatal or not?
Well, we'll take. Thank you so much, Ghada. That was greatly, very well covered. We'll take just a few questions before we go on to a 5-minute intermission break. So again, while on you were talking about in terms of tooth reduction, particularly for, let's say, the patient had tetracycline staining, beg your pardon, of all their teeth. So we obviously don't have to prep the teeth severely for every single tooth, because we're changing the color for all the 5 to 5 or something rather, right? So here's a very interesting clinical scenario. This viewer said that he was doing some gingivectomy because the patient had excessive gingival display. And once he finished, he noticed that the enamel that's now in the cervical region that's now exposed, it has this gray hue that I assume it wasn't there for the rest of the enamel. He's like, have you guys seen this before? Like, what do I do now? Do I use external bleaching of just that particular area to try to get rid of the gray hue? Or how come this subgingival enamel has this gray hue? I'm just wondering, is that tetracycline staining? Is that something? Obviously, we don't have a clinical photo, so I don't know exactly what this looks like. But any experiences with that?
With a tetracycline staining, it tends to be over the whole tooth.
I mean, it is band-like.
Yeah,
So depending on when
yeah.
those ameloblasts were secreting,
True.
right, at that time.
True.
The tetracycline was taken. So
True.
So it
I'm
does
not
sound
sure.
like some sort of intrinsic staining of the tooth, but
It sounds
it
like,
would
yes.
not have anything to do with the gingivectomy as such.
Don't think so.
This is just bad luck.
Yeah, does external bleaching work in just that cervical region? I haven't tried it myself.
I think it's very difficult to give an answer to something hypothetical. I think it definitely warrants actual diagnosis of why and what is causing the grey. Are we talking about all the teeth having a grey band across them chronologically, like you're thinking about, or you know, in terms of timing of possible tetracycline? Are they talking about one particular tooth that has
Or is it
the grey hue around the cervical aspect? Because then
to use the submit button to send us the file.
okay?
yeah, because then that may be any is there any cervical or resorptive issue just particular to that tooth? There could be so many differential.
Yes.
If the particular viewer with the question would like to submit a photo to us on the page, maybe we can answer this question particularly for you or help out. But on that particular topic, you know, it's one thing I forgot to mention in the medical legal aspect is on the cases in particular where this is the sound excellent patient, all the teeth are healthy and they have superb hygiene. This will be the case, an ideal candidate. They're mindful. Please do also still, regardless, chart and record all the 6-point periodontal probing charting, as well as vitality of the dentition,
Absolutely.
pre-operative X-ray. These are all very important before you commence the treatment. In particular, to add on that, especially in young girls coming in with excellent alignment of dentition, but maybe just minor shape change, please do ask them, have they had ortho before? Have they had aligners before? And also, have they had any trauma history? Because quite often what you may get caught out is as you complete your veneers management for them, they may not be mindful to go back to the previous ortho provider for a new retainer. Or they may have not actually mentioned to you that they had ortho until any minor relapse that may occur. Also, in the future of any tooth with trauma history, subsequently they may have any progression of any endodontic issue. So these are things that are important as well.
Thank you, Agnes. And one last question for you, Zoe, before we take an intermission break, which is, again, got to do with the mock-up bit. So this viewer said, well, they sometimes the mock-up material got stuck in between the embrasure, the black triangles, and then when they try to take it off, the whole thing is now locked in. Any particular tips in reducing that from happening?
That's right. I mean, patients who have a lot of diastemas, that can happen, or there's
Gingival recession, black triangles.
Black triangles. Be mindful of that. It's like similarly when you take a PVS impression of these teeth, the material could like get locked up into the black triangles, I suppose. I normally will keep an eye on it, placing a bit of Vaseline on the tooth before the mock-up. That might help make it easier to remove. And if there is a very prominent area where you are worried about material being locked in, even on the palatal aspect, having a piece of wax,
soft orthodontic wax,
absolutely, pushed in there, partially blocks that space. That will help make life a lot easier to remove. For sure. This mock-up.
I think that's very fundamental, of course, is to be mindful of actual undercut locking in. But another important aspect to consider is to actually make sure that the model of which you create the putty on is of good high resolution or high detail, so that when you fabricate your putty key, it has a very close approximation all along the gingival, the cervical area. And that when you are placing it intraorally, rather than overloading a lot of material, or just be mindful of the excess to be as thin as possible, so that it can peel away and you have thinner section to so manage rather than.
That's right. So you can adapt it as you apply the mock-up, push on the buccal aspect, and that will make the layer quite thin. Labially, which can be removed as an excess material.
Yeah, I find sometimes if the work doesn't say in the expensive way, just inject some light body, quick setting light body, so you can do like, especially when there's a lot of diastema, you can just inject very quickly at once and then do the mock-up.
Okay.
But that's a more expensive way of doing it.
Yes, sure. And then there was another question about, what about for post-ortho teens? As in these are very young patients, teenagers. There's still diastemas. There's B. What do you do? Obviously, for a teenager, I personally wouldn't consider porcelain veneers. I'll use composite resin wherever possible. They're still growing. There's a lot of changes and movement to be done. So nothing that will lock them in.
But I think this particular question is more. It makes us all have a good think about it. So prior to your completion of your ortho, or as you're deciding with your ortho treatment plan, there should already be a discussion whether you want to consolidate and close that space, or that you will complete it, like Dr. Bentley had said, one side with a composite veneer, so that you achieve a bit more balanced outcome. What is the prognosis of that bee? What are the intention of how long that bee is going to stay in the mouth? And as opposed to if you are met with someone who's already had their ortho finished, they may have consented to consolidate space at a particular time, but now they change their mind. They do want to have a little bit more balanced outcome. Then it's a different conversation to have in terms of the different types of options altogether.
Thank you, Agnes, and thank you so much for your questions and joining us, ladies and gentlemen. Very soon we're going to take a 5-minute intervention break. So in the meantime, feel free to continue to send in your questions, or even to use that submit button as you scroll down, so you can actually send us in a lot more information, including whether it's a X-ray or photo or something rather. And then Brett here, he will be directing me with those sort of imagery for us to have a better understanding of your questions. So we'll take a 5-minute break. Feel free to fill up your bottles and your popcorns, and come back and join us in 5 minutes.
There are many suture companies around the world, but only one that is truly Australian. Being a major manufacturer of surgical sutures is not something that Dynex takes lightly. An absolute commitment to exceptional service and quality has seen us develop into a global business, exporting to countries around the world. With more than 50 years' experience in the industry, Dynex is exceptionally proud of its Australian origins. Our head office and state-of-the-art manufacturing laboratory are located in Adelaide, South Australia. It is a commitment to local manufacturing with an international focus that has seen our company rapidly expand into new territories, building a reputation as a leading provider of the finest surgical products. Relationships are crucial to the ongoing success of DINEC, and we're extremely proud of the associations that we've created with all members and areas of the medical profession. Consultation with medical practitioners has required DINEC to finely tune its research and development. This has resulted in the creation of thousands of different kinds of single-use, absorbable and non-absorbable suture types. Production of DINEC sutures runs into the millions every year. DINEC is very proud of its manufacturing facilities. It is here that we continue to make significant advances in microengineering, which have enhanced productivity. We've attained the CE mark and ISO 13485, the internationally accepted and demanding quality standards for medical devices. Capital expenditure in research and innovation is focused on the benefits to the medical profession and, most importantly, the patient. Rigorous testing and quality control ensure the standards of safety that are essential in such a highly invasive medical device. DINEC has developed its own easy-to-use labelling system, adhering to the international colour coding system. This makes it easy for surgeons and nurses, hospitals and clinics, in fact all practitioners, to transition to DINEC sutures. Many needle types have been developed over the years. This range, coupled with the strength of the attachment of needle to thread, gives unprecedented control and accuracy during the most demanding surgical procedures. While we are immensely proud of our reputation in the medical industry, we understand that none of this would be possible without our amazing team of professionals. Since the early days, DINEC has maintained an environment that encourages creative thinking, open lines of communication, trust, integrity, and honesty. We're pleased to have retained many of our staff members for more than 20 years. From researchers to assemblers to its sales team, DINEC understands that continued training is vital to give staff new knowledge, skills, and job satisfaction. We recognise that our business is in the hands of our people, and our future success lies with our staff. DINEC is a truly global business, expanding into new territories every year. We are the suture of choice for GPs, medical clinics and hospitals throughout the Southern Hemisphere and beyond. Our team of professionals is ready to help you with all your suture needs. Contact us today.
Thank you, ladies and gentlemen. Thank you for joining us back again. Just a quick reminder for the ones that want a CBD certificate, please do scroll down to the bottom and fill in your email address at the bottom of the page where it says please enter your email for CBD certificates. Once again, on behalf of the group, I would like to thank each and every one of our dentists that's joining us tonight for trusting us with your patients. We deeply appreciate each and every one of your referrals. We do not take it lightly at all, and we are endeavored to work very hard to make all these patients as happy as possible. And lastly, a quick mention of the sponsors, Noble Bowel Care and DINEC. For the ones that's interested in your implant program or implant training, beg your pardon, check out the Noble Bowel Care Mentorship Program 2025, and for DINEC, for all the surgically involving dentists who's looking for sutures. They do make some fantastic sutures, and there's a 15% off for tonight. So now that Ghada has expertly covered the different type of preparations there are, including how much to reduce, I absolutely agree for those teeth with severe discolorations that you would otherwise need a lot of tooth reduction. Again, you've got to think hard about, is this still a veneer case that I'm doing, or is this going to be something else, given the degree of discoloration, especially if you're matching like a single central or something matching to the other dentition. So now that we've prepared the teeth, next phase is we're going to take some sort of impression. We know that a lot of the cases could be quite simple, where your veneer margin could be supragingival. That's like a slam dunk of impression, but there are some cases that's not as straightforward. Johnson, could you take us through some of the tips that you may have in terms of how to go about taking impressions for some of these more trickier sort of type of cases?
Yep, great. Thank you very much, Ben. So if we look into most cases will require a restriction code of some sort, because if we are changing the shape and also the color, our margin needs to go for equigingival. And it will depending on your gingival biotype, and they will determine the size of the restriction code you use. So if we go for the thin biotype, if we go for equigingival, we will pick one piece of 000 restriction code. And if we are doing multi-unit, then it's better just to use one piece and pack all the way down and wait for minimum of 2 minutes, but I usually wait for 10, and then before you do the impression, just pull the retraction code out, and then you can do the impression. For the multi-unit, sometimes if you don't capture all the teeth well, you can just retake the impression in the tooth or the teeth that doesn't have as much detail, and your dental technician can rejig the models or the die space, die stones, or the section die together. Yep. And then, or, sometimes you can, chill the light body impression material, and then that prolongs the working time, and then they give you a little bit more time. Or sometimes you can tag team. So 2 dentists, one do one quadrant and the other do the other quadrant with the light body, and then use the heavy body.
Divide and conquer.
Yep. Once we pick the retraction code, like in this case is a more thick biotype, so I pick one size 0 retraction code. What we want to see is ensure we stretch, and then we can see the margin. This is a severely tetracycline stained teeth. I mean, she had previous composite resin veneers for about 20 plus years.
Wow.
So it took her a while to work up the courage to go to the next step. We discussed ideally we can give her translucency, more natural appearance using crowns, but she wasn't ready, so she's decided to have porcelain veneers. So because she chose a color of a more 0M3, it's a whiter shade. So the whiter the final shade, that means the less we have to cut, because the whiter shade can block out the discoloration better. So in this case, we wait for 10 minutes, and then we did the impression, and then later on we cemented the porcelain veneers. My ceramics used a LT, so low translucency in this case.
Wow.
Yeah.
I thought they would use maybe a high opacity.
Low translucency.
Low translucency.
Sorry, beg your pardon.
Low translucency. Yeah.
Do you recall how much tooth reduction did you do for this? Just very roughly?
Very roughly, I did about 0.7, but as you can see, like her previous composite resin veneers, in the gingival part is a little bit thicker.
Yes.
So even though I did 0.7, but my ceramics added a little bit more ceramic in the gingival portion to mask the discoloration.
Yes.
Yeah. And then the next part will be for the ultra conservative dentist. When we do the veneer prep, a lot of time we cut through the interproximal region. But for the ultra conservative dentist who wants to preserve or as much enamel as possible, so what they can do is their impression technique needs to be a little bit different. Because if we just do the normal impression, when your dental ceramics comes to section the die so they can check the marginal fit, what they do is if you don't give them the interproximal clearance, they can cut the teeth, basically damage your die, and your veneer will not fit perfectly. So what we do is we embed a part of the malar matrix in the impression material. So this is a different view. So when it comes to the working model, they have area they can cut and then to produce your working model. But the disadvantage of this is, of course, because you've cut, that means they need to be quite experienced, and your general veneer will be a little bit wider. So you do need to spend a little bit more time adjusting the interproximal area.
This is equivalent of putting some wedges in between every teeth, isn't it? I mean, if you had
Yes.
like 10 units, that's like 10 wedges put in.
Yes.
And that really expands that teeth quite a bit.
Yes, yes. So The other option would be in this area, when you are cutting through the proximal area, the enamel is quite thin anyway. So what you can do is you can get a metal strip in there just to remove a little bit of the enamel. What that allows is it give it a little bit more space for your dental ceramics to section the die. So it's important to section the die, so basically they can check all the marginal fit, especially in the proximal area in the section die model. And then they also have a master model to give a overall picture and also the proximal contact. The other tip would be if you are doing a multi-unit. I know this is a crown case, not the veneer case. One way, as we described, would be to do one step where you inject the light body and also have a heavy body which sits all at the same time. But your timing for the light body is really not a lot of time. The other option would be to do what we call a two-step impression. So after your preparation, my general go-to would be to pack the first 000 restriction code, and the second would be the 0 restriction code. We wait for about 10 minutes, and that will give you quite a bit of sufficient time to work on your impression. The difference with this two-step is after the second code, you do a heavy body impression PVS. And then you have to cut all the undercut and also the proximal area. It's important to do the vents on all the teeth, not only on the teeth you're preparing. Otherwise, if you don't do all the vents, sometimes that might lock in. You may not be able to push the impression back all the way. The difference with this would be, rather than inject light body, which will be sweating on the teeth, you push the light body onto the heavy body impression. But because they basically no space, so all the light body will push into the margin. So it makes your impression much more predictable.
So it's using the pressure that you're forcing this light body into all the sulcus
That's
spaces.
right.
You know?
So your tray will basically sort of inject that light body into the sulcus. But the difference, if you look into the study, whereas your one step would be a more passive impression. When you remove it, there's a little bit of distortion. So usually your working die is a little bit bigger than what it is. With the two-step, because there's really no space in the heavy body, but when you push a light body into the heavy body, and when you set, the heavy body actually push back. So your working die is actually 200 microns smaller. So your ceramics for the one step, a lot of them reduce the die spacer. So basically give you a more close-fitting crown. But with the two-step, they actually need to increase the die spacer. Often you have to ask for 2 to 3 layers of die spacer. So you don't.
Do they put it still in? I mean, normally when they put 1 layer or 2 layer of die spacer, they don't put it in the margin, right? They just put it in the spent space. But for the two-step impression, do they also increase the layers in where they normally put it, or do they extend it now into the margins as well?
No, they don't extend into the margin. They just put where they normally put it.
Thank you, Johnson.
Great. Thank you, Ben.
Great tips to have. Chilling the impression, material, or working in tag team, or using the two-step impression technique. So now that we got a great impression, we send it to the lab, but we can't send the patient home with the teeth being prepared. Right. So Zoe, building on what you've taught us in terms of all the different options in mock-ups, how do we provisionalize these teeth, which is not only so that it's biologically healthy for the teeth, but also aesthetically pleasing and a great communication tool? How do we go about provisionalizing teeth?
Sure. Thanks, Ben. So with the provisionals, depending on what kind of reduction you've done, so it's all based on the diagnostic mock-up. It's all based on your wax up that you have generated for the patient. This is the template that you'll use for the provisionals. It can be very difficult for veneers. It's unlike crowns where you've got a lot of space. Veneers can be very thin, especially if the patient has had minimum reduction or no prep at all. They can break easily, difficult to remove from the mat. They can be locked into proximally. So occasionally in minimum prep or no prep veneers, some clinicians may elect not to provisionalize the patient at all. And the disadvantage, well, the advantage is a quicker treatment. Patient walks out of the door. You're not spending time on that. But the disadvantage is the patient will have the perception that the width of the buccal lingual dimension of the tooth is much smaller than what it will actually be. So on the cementation of the veneers or trying of the veneers, they may have the impression that it looks or feels too thick or too bulky. But so that's why it's always better to send the patient home with some sort of veneers that will give them a shape of their expected outcome. If we have changed the tooth shape or form for any either diastemic closure or for rotational correction, alignment correction, color change, then we will have to provisionalize this patient. So the best way of doing it, of course, we've talked about the mock-up, whether it's digital model or a wax-up model. You generate a putty key from that model, so a PVS putty matrix. And you can use like a solid color or a clear color depending on what sort of provisional restoration you will be providing for the patient. And if you notice on this, there's a lot of like a V indentation or reduction, and that corresponds with the papilla area. So it's just a V-shape reduction just to help the material to vent out of the putty matrix. And then you can clean it up with some like a small sort of Q-tip or microbrush, something like that. Sorry.
It's 9 o'clock. It's 9 o'clock. It's fine. Yeah.
That's it. Okay, so so one way is to use a flowable composite resin. So you've got your clear putty for this case. Just make sure that you clean up on the palatal, 1 millimeter. So remove any matrix extending beyond 1 millimeter of your prep margin. And that will help to clean up any excess material that might flow on the palatal. Then you spot etch the teeth that are prepared. So not every tooth has to be spot etched. It could be alternate teeth. And just to make it easier later on when we come back to remove the temporary veneers. So spot etch and then an unfilled resin on that. And then inside the matrix, you can inject your flowable composite resin and then adapt that onto the teeth. Make sure that you put a bit of pressure on the buccal aspect near the gingival margin to minimize the thickness of the composite. So minimize any cleaning potential later on. And once you remove it, you can come back with either a scalpel or a fine, but just be careful not to damage your prepared margins. So this is one way of doing that. Of course, they're all going to be joined together. They will be bonded, so you will be unable to remove this once it's set. And with setting the composite, it's important not to set it fully. So 8 to 10 seconds initially, remove the matrix. It's easier to clean and remove the excess composite when it's not fully set, and then complete the set process. The other way is same. You've generated your matrix, PVS matrix. Remove the cervical 1/3 of that matrix on the model. So on your working model, not inside the mouth, just cut off all the cervical, just showing the tip of the papilla, so incisal to the papilla, I suppose. And again, using composite, flowable composite resin inside the matrix, ensuring not to overfill it, so maybe 2/3 of the tooth space, and then seat it, and again with the micro brushes, remove any excess composite material that might flow out on the labial. Light cure it And then just sculpt the rest of the restorations by hand. Freehand, apply all the composite to cover the cervical portion of the tooth, and that way it will be easier to carry out this treatment, because all the incisal occlusal aspect is done. All you have to do is layer the cervical portion of this restoration. So something like that. And then again, finish and polish your restorations. The other way is what most people will likely to do is using a self-cure bisacrylic resin. So any patiki, again, you've got to trim it to enable the removal of excess. And using that, apply it onto the tooth surface. Make sure that you wait with the bisacryl resin. Make sure that you don't remove it when it's in gelatinous form, because it will, because of the thin nature of the veneer, it will rip and tear, and then you will have to remake it. So just wait for it to fully set. And so initially, maybe put some, expel some drops onto your gloved hand before you inject into the matrix, and then seed that in the mouth. So once that has set, that gives you an indication that it's ready to be removed. And then gently remove this provisional restoration. So this is not bonded yet. Remove it. Carry out any polishing, finishing, recontouring. So I found Softlex discs very easy to use to trim up to the margin. And then you can finish it with and polish it with a composite polishers. And if you want to add a bit of sheen onto it, then unfilled resin, it will, like a glaze layer, will help preserve the color of the provisionals, as well as fill in any porosities or imperfections onto the restoration. So once you've finished and polished it, then you can come back and cement it in place using that spot etch technique, where you're applying the bond onto that spot etched layers, and then a flowable composite to, you can sandblast the inner fitting surface of the acrylic veneers as well to improve the bonding if you wish, but generally they will bond quite well. And then it's already finished, polished to the margins of the restoration, so you don't need to do much trimming after it's already cemented in place. So now we show you this case. So remember, before you're doing your provisional restoration, to send the lab a photo of your stump shade. So this is important. The lab will need that for choosing their ceramic coping layer or ingot layer color. And then once you've done your provisionals, that is, take also some photos of the provisional restoration that the patient has approved and happy with, and then the ceramist will convert that into a definitive restorations. So I'm going to share with you this case here. There was that young lady. She is a trauma case where she was hit by a horse. So tooth 1-1 and 2-1 were devitalized, and 1-1 has fractured. So there's a complicated crown fracture involving the pulp, and then 2-2 had an uncomplicated crown fracture. So the tooth is still vital, and they managed to re-cement that portion of the tooth back on. But she was very traumatized. She was very anxious, unhappy with her overall aesthetics, and traumatized by the whole ordeal of the injury. And so she was a very anxious patient to treat, and had to kind of tread very carefully and make sure that she's happy with every step, make sure that she's not overwhelmed by the procedure. But she wanted to preserve as much tooth structure as possible as well, having gone through the trauma. Her first thing that, I don't want to have my teeth cut, I don't want to have any sort of excessive reduction that more than what is needed. So looking at assessing these teeth, looking at assessing these teeth, we kind of had to work out which teeth can be to improve the overall aesthetics. We talked about teeth whitening. We talked a lot about which teeth to include for the veneers and which teeth to include for the crowns. So it was decided that 1.5 to 2.5 will be treated. All of them will have the veneers from 1.5 to 2.5 with the exception of tooth 1.1, where it had a very large composite resin restoration, and then tooth 2.2, where we had that fractured bonded part of the tooth that was positioned. I just wasn't quite comfortable putting a veneer on that tooth. So there's 2 teeth that had the crowns, and the rest of the teeth had, the rest of the 1.5 to 2.5 had a veneers. So we had to go through a few phases of provisionalisation just to make sure that she is happy, comfortable, and then communicate that back to the lab to get her final results. So this is the final outcome for the patient, where she was quite happy with her look, thinking this is me. I've gone back to where I was before the trauma, and tried to conservatively remove as minimal tooth structure as possible within that limitation of the treatment.
What a beautiful case.
Thank you.
All the horse trauma patients that I've treated don't have teeth, so the fact that she still got her teeth, I think that's she's a very, very lucky girl. One of the questions from the audience said that very problem that you mentioned earlier happened to this clinician as well, which is the patient had no temporary, because obviously it must be a very minimal or no preparation sort of situation.
Yes.
And then later on, when they gave the veneer to the patient, oh no, now it's too bulky, too long.
Right.
Patient was unhappy, so therefore they have to cut it off and redo it. So the question is, what can we do about that? I think he's is asking, how can we get away without doing a provisional? My gut feeling tells me I don't think you can. I think you just have to do a provisional. Any thoughts on that?
Or at least at a mock-up stage, you'll have to do some sort of a mock-up just to show them. And if you don't end up doing the provisional, you've run out of time. You didn't have time for the provisional. It kept falling off. You've got to tell the patient, I haven't put the provisional on. It's going to be thicker. It will be similar to the mock-up phase. Ideally, you'll end up doing a provisional, like you said, Ben. But if you can't manage it on that same session, explain it to the patient. Tell them that it's going to be different, not what you're walking out with.
Yes, I strongly recommend a provisional, simply because sure, your veneer might be 0.75 or whatever millimeters thick, but to the lip, a lot of patients, they have very high oral acuity. So anything that you change, they go, oh my goodness, this is way too big.
Especially the length of the teeth, that will be quite different.
And a question going back to you, Johnson, regarding impressions, that 2-step technique. So you got your first chord, you got your second chord. Now, when you did your first putty/base impression, that's still with the second chord on.
Yeah, still with the second core out. But you wait for a little bit because it can pull the second core out.
So when you say you're going to wait a little bit, you mean obviously you're going to wait for it to set. 3-4 minutes.
Yep.
Afterwards, do you wait any additional time? Is that what you mean?
Oh, no. I mean, you wait for the retraction cord to stretch the gum.
Oh, yes.
Yeah.
So yes. So first chord in, second chord in.
Yep.
We waited already 5 to 10 minutes.
5-10 minutes.
Okay.
Yep.
So now we're ready for the impression.
Yep.
You got your heavy base.
Yep.
Your heavy body PVS.
Yep.
And then when you pull off, often the second chord,
Chord
right?
come
so
up.
to
Yep.
come with it.
Yep.
And then second chord out.
Yep.
Light body in, right?
Yep. Correct.
Fantastic. Okay. Scanning. I think scanners, there was quite a few questions on scanning and impressions.
Yep.
Any thoughts on that?
I think I'm not. Others may be able to help out with the scanning, but I mean, generally with the retraction cord, generally the concept is the same. You want to make sure you can see the margin with scanning or impression.
Absolutely.
Yeah.
It's to make sure that we're not scanning something that's many millimeters subgingivally. We all know that there's a lot of studies showing that the more subgingival you go, the poorer the quality of your impression.
Yep.
Secondly, because of intraoral scanners, it's a stitching type
Yep.
of situation. So when you start from one end,
Yep.
you go to that end, your greatest error is always at the other corner.
Yep.
So we covered this sort of concept in our previous webinar on improving impression taking, so feel free to check out that. So now that we got some provisionals in and we are having to decide which type of ceramic that we're going to choose for our ceramic veneers. I hope we're not going to leave that decision 100% in the hands of our ceramist, which I know sometimes that's what happens, but I think we should have a better understanding of what the materials are and what the physical limitations and optical properties that they have, and so that we can tailor that to our clinical situation. And often, of course, it's a team effect, so there's nothing wrong with discussing with your ceramist, hey, which material do they think can get us over the line in terms of whether it's blocking out, especially with discoloration. So there's two main type of materials I think we tend to choose from. One is feldspathic porcelain, the other is lithium disilicate. So feldspathic porcelain, we all have learned about that in our undergraduate years, where it's made primarily of feldspar with a little handful of quartz to give it structure. And when you fire this material somewhere around just over 1,000 degrees, then you get it started to form these lucite crystals. And anywhere between 0% to up to, I think if I recall correctly, something like 15% or close to 20% is still classified as feldspathic porcelain. So there are some variations of how much lucite crystals are contained within the lucite crystal that your ceramic uses. But by and large, the material is made out of glass with a handful of crystals. So typically, if you haven't seen a ceramist work using these materials, they use these pigmented powders, and they mix it with deionized water. They pigment it so that they know exactly what shade or what translucency these materials are, because they stack them one on top of each other in terms of whether it's a dentine material, a translucent material, and then later on an enamel material. So if there's no pigments at all, then they have no idea where they just put what. And it always looks really fat because when you fire ceramics, things shrinks about 25%. And then especially around the margins, you don't want a gap, so they add more ceramics. So typically for a feldspathic porcelain, they got to do this, stack it, fire it, stack it again, fire it, at least three, 4 times during this process. And then of course they have to reshape it, just like how you and I shape composites. We may use some pencil marks, they use diamond burrs, and then some sort of polishing. Some uses glazing, others use some sort of pumice. They have their own tricks up their sleeves. However they do it, they'll polish it. So for example, in a case like this where the tooth's natural color, we don't want to do too much changes. Patients happy with the color of their natural teeth. They just want to improve the shape or the orientation or the general buccal appearance of these teeth. We're not lengthening the incisal edges at all. So therefore, and there's plenty of natural tooth enamel, therefore very minimal preparation, feldspathic porcelain goes on, pick up the natural color of the teeth, and that's pretty much it. So regarding these materials, it's usually indicated for teeth with very little color change required, perhaps very little tooth reduction required, usually not for very thick, particularly around the incisal edges, because if you make these things that's like more than, even getting close to a 1.5, not even to say more than 1.5, you're definitely going to have a higher risk of things from chipping, particularly during in the incisal region. So they're well indicated for low stress or tensile stress type of areas, and ideally for patients with mild or low para function. Sort of your ideal type of cases. Then moving on to the next material, lithium disilicate, which there's a few different brands now. You've got Emax, LithiPress, things like that. The first one was made by IPS, which is called Emax. So these things are it's a very unique crystal, which is roughly about 70% of the material is in crystal, which is like these sheet-like or plate-like crystal structures in random orientation when you look under the electron microscope, and then roughly 30% in glass. And the reason why all of a sudden they have significantly higher flexural strength is because now if you're a crack and you want to travel from one end of the material to the other, well, now you have to navigate through 70% of this random sheet-like crystals. So therefore it takes you a lot longer to go through this material, and hence the significant increase, I think somewhere around 350, 400 megapascals in flexural strength. Studies have also shown us that when you etch these materials, particularly when you're using a separate etching process, and Agnes will go through bonding protocols with it a little bit more, you can typically see that you're opening up the crystals a lot better. So these materials are designed for you to etch just like your feldspathic porcelain before you decide to bond. I also want to just spend just 1 or 2 minutes covering how these things are made, just so that you have a better understanding when you're communicating to your ceramists, when they talk about terms like pressed, layered, monolithic, what on earth is that all about? So how they make typically these lithium disilicates is first they do a full contour wax up, kind of like how you make full gold crowns, right? You use some wax of some sort. I mean, these days you don't have to technically use wax. They can be even printed, milled or digitally designed. You don't have to do it by hand anymore. But there's some sort of a wax sort of pattern. They will invest it, again, same as how you make full gold crowns. But then instead of shooting in gold, you're now shooting in a molten, almost like a rubbery sort of consistency of hot ceramic material, which are pre-made nuggets, which are what they call ingots. So there's a variety of different translucencies that the team has already spoken about, whether it's low translucency, high translucency, medium opacity, etc., and a lot of different colors as well. So for example, with this Emax material, they have this very complicated, or I shouldn't say complicated, but a very comprehensive table in terms of, on the left side, it even tells you if this is the stump shade you have, and therefore, and you want to end up in whatever shade you are, let's say B1, then it even tells you what are the different options of material that you can choose. So lots of different translucencies and colors to choose from, and then when they shoot this material in under pressure, they devest the material. They at the moment just look like sort of opacious sort of veneers or crowns. They don't look very lively at all. And here is where part of your lab prescription makes a difference. Is that now you're going to tell them, well, is your veneer or crown monolithic or is it layered? Because that makes a big difference. If it's a monolithic restoration, that means that this material is made out of just one thing. So your ceramics will now just stain the material from a buckle aspect to change the chroma, the color. They may use some sort of blue or gray color to give the illusion of translucency, but it's not real translucency. So therefore, your translucency is less than the next version, which is layered. Layered restoration, as the term suggests, is made up of more than 2 different materials. So typically, it's feldspathic porcelain layered over the lithium disilicate material, beg your pardon. So for this case, being an interior case, we want things to look a little bit better. So they first did a putty key of this, and then they just hand cut back the Emax material so that they could hand stack or layer the feldspathic porcelain over the top. Again, they fire it a few times, and voila, you have a slightly more translucent incisal edge. So now aesthetics went up, but in terms of the potential rate of chipping or mechanical complication, now you've increased that a little, because now that material is, because it's lithium disilicate, so the flexural strength is less than lithium disilicate, so you have to tailor, you have to weigh up and down between aesthetics and the amount of force that this material is anticipated to withstand. So because this material is, in simplistic terms, stronger, so therefore it's more indicated for areas that perhaps there's patient that's more stress, or patient has a little bit more parafunction, or your incisal edge, you need more than lengthening by more than 1.5 millimeters, right? You need a stronger material, or you may even need to block out the discoloration just a little bit more than before, because you can use a slightly more opacious material in this range. So ultimately, yeah, I believe we should have a team collaborative approach to material selection with our ceramists, as opposed to just getting our ceramists to pick the material for us, and it becomes a Kinder surprise. Johnson, you work obviously a lot with ceramists and some of the high-end ceramists too. Can you tell us a little more about how do you communicate to your ceramists so that they have a really good understanding of what you want to achieve, and particularly photography, because
Yep.
you take some amazing photos.
Yeah, great. Thank you very much, Ben. For interior cases, I think it's very important to have a nice camera so we can communicate the character of the teeth, but also the color to the ceramist. For the character of the teeth, I mean, if you just take a photo of the teeth, you don't see as much detail compared to a black contraster. The black contraster can be hard material, or sometimes they put a silicone layer, but I tend to find, although silicone one, the soft one is more comfortable, but it tends to start to come apart after about 1 year. It's also depending your flash angle as well. If you take it from a perpendicular angle, you get a lot of flash reflection compared to taken off slightly about 30 degrees of angle, where you can see the character, the translucency, the white, or the color of the teeth, the character a bit better. There's also the option of using a cross polarized filter, so that takes the reflection away compared to the normal non-cross polarized. These are one version, created by Polar Eyes, which comes with a different flash. It can be ring flash, or it can be twin flash, and it comes with a different brand. The other important part, the second part, will be talking about taking the shade with the lab. So you have the traditional one of using a shade guide to speak to your ceramist on which shade guide they prefer. Some prefer Vita Classic, some prefer 3D, some prefer the Ivoclar. I tend to find if the shade guide matches with that tooth exactly, you can put just one tooth. However, if it falls in between, it's better for you to have 2 or 3 shade guide. And it's important to do the shade selection at the start of the appointment before the teeth dehydrate, but also to put the shade tape at the same plane as the teeth, so you get the equal amount of reflection. The second way to do it would be with a white balance card. The way it works is the white balance card will take the shade and also the character at the same time. So the one on the left is for the shade, but also they take one without the filter that will show the texture of the tooth. It's a really powerful program, so you need your filter, you need your white balance card, and they have a software that will tell you what ceramic powder to use. But generally, your ceramist will spend 4 to 5 times the time compared to not using one. So it does really increase their time. But it's really good when, matching a single central, there's a lot of different characters, a lot of different staining. Traditionally, if you want to match it well, you need to have like 5-6 try-ins. And with this method, you can do it in one go. But my ceramist told me he spent 2 days. And he had like 60 so try-ins. So it does really increase their time, but will give you a more predictable result. The third part would be communicate the stump shade with your lab. It's important to do this before the tooth dehydrate as well. So always match to the darkest part of the tooth. It can be either done with Ivoclar, Vivadent, Natural Dye Shade Guide. They do have a matching composite resin in the lab where they can check the color by using a resin dye, or it can be any shade guide that comes closest to it. Both will work. There are different ways, your dental ceramist can try to mimic the discoloration. Very simply, some of them will use their stone, they put a texture to mark it. Some will use a natural dye material, and some of them go to the extent of doing their own resin and then put some staining on it. They all work, but the most important part is, they want to be able to mask the discoloration. Yeah. Great. Thank you.
quite often we do cases when you got a crown and then you got a veneer
Yep.
kind of almost next to each other because of a different clinical situation.
Yep.
How do you go about ensuring that the final result has the same color?
I see. It's basically quite often when when your dental ceramists they do a crown and the veneer, they choose a different coping in color. But to match it exactly the same, they need to use the coping of the same color, and then have this coping to the same depth, and then they basically start building the porcelain from there.
So this is assuming they've used the same material.
They use the same material.
Yes.
Yeah, so it's important for the coping color to be the same, but often they use different coping color, and hence your result is a little bit different.
And if you have a veneer, let's say a feldspathic porcelain,
Oh, I
right?
see.
So what you're saying is that, for example, it would have to be in both lithium disilicate.
Pretty much same
Okay.
material, same coping color to
Okay.
give you the best predictable result. Otherwise, if you use one feldspathic and then one you have to block out, that's almost
Versus
impossible.
one PFM crown.
Yeah,
Good
that's-
luck.
Yeah, that's
Yeah.
almost impossible.
Yes.
But the
Yeah.
thickness of the coping on the crown will be thicker, so it
Have to
masks
be
the
thicker.
underneath layer.
Correct. Correct. Yeah. Yeah. So the coping have to be a bit thicker because your veneer is a bit thinner. So
Yes.
basically, the final build-up porcelain layer have to be very similar.
Very similar.
Yeah.
Yes, absolutely. A lot of technical
Yeah.
changes, isn't
So
it?
it's more telling the ceramist what to do.
Exactly, exactly. So it's great to have that foresight.
Yeah.
Thank you, Johnson. So now that we've told our lab, communicated with our lab appropriately, exactly what sort of material and shade, etc., and this restoration has now back into our hands, and now we're supposed to give that to the patient. So Agnes, can you go through with us, how do we glue these things in the patients now so that they don't fall off?
Okay. We are approaching the end of this webinar.
We are.
And I think let's talk about what people are interested in foremost, which is trying. So when we are trying in these final veneers, just a few tips. Even if you may be thinking that you will be using a clear translucent type resin cement like cured, and a lot of young focus, we're going to be having a dry field. We're going to have excellent gingival health, dry field. But it's very important that as you're actually trying in your veneers, due to the optical properties, either A, use your trying paste, or B, if you're not using trying paste because you're going to think we just want the exact shade and we're going to be using clear or translucent resin, then please do make sure that this is not a dry field kind of exercise. This is a wet field exercise. Pop a drop of water into the integral surface of your veneer and try it in, because it does influence the optical properties. So if, for example, your patient is consenting to what they look like, when the tooth is dry, your veneer is dry, and you try it on all dry, and that's commonly when you then cement it on, and you can see it yourself too. Oh, it does look a bit different to when we did it. I can see what you see, and then you may find it a little bit unacceptable.
And there are some clinicians that actually uses a cementation consent form as part
Yes.
of that previous medical legal aspect. So what they do is that either with or without photography, right, during that that try-in phase, they then get the patient to sign a separate consent to say, yes, I understand this is now being permanently glued to my mouth. If afterwards I have a change of mind, sorry, there's no going back. And some clinicians even take a photograph of that veneer with a clear try-in paste in their mouth. And that photograph is put into the cementation consent form to say, hey, you consented to this color. So there's
So
nothing
I mean
can do afterwards.
that's as much as you can do. But just talking about the technique sensitivity, if you are trying in your veneer without trying paste and dry field, yes, optically it can be different to the final cementation result. And I think that's important to a message to share.
Absolutely.
Now, on the proviso that along all this way, like, from mock-up, all the detailing, you do arrive into your final restoration that you're happy to cement. Of course, now you will be doing your cementation consent. And as a clinician, you really want to ensure that you can glue them in properly too. So if you're doing multiple veneers, it's important that if your early career, make sure that you do rehearse and try in to ensure the proper seating and locating the veneer. If you're doing both centrals, it will be helpful to do both central together. And then, if you're doing like what Zoe does, she shared with me, this is actually her message. After you do your 2 centrals, is you do your 2 first premolars, and then you can do your lateral and canine. Yes. However, the final message still to be is that you must, even though you've tried in everything in one go to receive your cementation consent, as you are trying in these, contralateral pairs, before you actually cement the next set, it is so important, just to avoid little discrepancies in the proximal contact, to just, again, try it in before you prepare the surface. Now, as we go on to the next part is about bonding. So when we talk about bonding, essentially, we want to bond the restoration to our teeth. And hence, it's not hard to understand that we kind of have to prepare these surfaces and prime them or wet them in some sort until they are now ready to be glued together. There was a question about light cure cement or dual cure cement, what is preferable? So light cure cement will have better color stability, although it is more technique sensitive. It really does require a nice dry field and your own control to be able to clean up, tack cure, and remove the excess cement. But it does have a much better color stability. So that is my preferred light cure cement. Often the veneer thickness does allow the good light penetrations as well. So moving on from that, let's talk about the type of things we're bonding to, because whatever we're bonding to, whether it's restoration or teeth, it matters. In general, when we talk about gluing something on the tooth, it's not just on the tooth. There are different substrates that matters. So if we go to the slide, we can have enamel, we can have dentin. A lot of the times it's actually enamel and dentin, because let's face it, around the cervical area, literally, by the time we do prepare even 0.5 to 0.6, at the cervical aspect, most anatomical literature you refer to at that CEJ, by the time you prepare 0.5 to 0.6, you hit dentin. So most of the time, really, when we talk about, a lot of the day-to-day veneer preps that we are dealing with, we will be doing enamel and dentin. One more thing that's not shown here, but I will still lightly go through, is we do also bond to composite resin, because there will be times where there will be small aspects of restoration that is left on the tooth. So when we talk about enamel bonding, we're talking about a micromechanical interlocking. So we would be using your acid etchant, which is commonly 37% phosphoric acid, to create these micro pores that you can see on the electro microgram. So this irregular surface gives the actual mechanical interlocking, allowing the resin tags to be flown in to penetrate into these pores. And as we know that enamel bonding is a lot more stronger than your dentin bonding. But in the end, there are still some factors to consider, namely, how sound is that enamel? So most enamel, once we do etch it and we dry it, we quite happily, and it's almost like a excitement to see that frosted enamel. Oh yeah, I've etched it well. So that etched appearance, that white frosty appearance, remember, that's a loss of mineral content. If you come across, as you prepare your teeth, that before you etch, you do see these white opacities, that means that's an area of enamel where the quality is already innate, a bit more damaged or porous. So think again whether you really want that restoration to be finishing or sitting on that type of enamel. So what we also know is how long we etch this enamel. So we know that if we under etch it, we're not going to get enough strength because the resin tag just doesn't go in as much. There's not as much a mechanical bond. If we over etch it though, we're weakening that enamel structure too. Therefore, it's not as sound to bond onto. So commonly what we do know is we etch the enamel somewhere between 15 to 30 seconds, and ideally we would recommend 15 seconds. Okay. And studies have also shown that if we etch the enamel separately using the 37% phosphoric acid type etch, you do get a better bond strength than compared to the all-in-one bottle self-etching type scenario on the enamel. So overall, this is how we will advise our patient who are undergoing any type of adhesive bonding procedures, including veneers, that we really want excellent gingival health, excellent oral hygiene. If need be, they may have Clorox mouthwash 1 week prior to really trying to promote that good gingival health. And therefore, we will then be able to work on these parameters accordingly. So it does matter what we, bond under. So after enamel is we're going to talk about dentine. Dentine bonding is all about forming a hybrid layer. Now, no matter what type of, system we really are looking at, creating dentine bonding techniques, you can have different generations where all 3 steps, different types of 2 steps and 1 step. But all in all, 3 things got to happen. First, we have to acid condition. I like to use the word condition because we actually don't really want to over etch this dentine. And the etching process is quite different to etching enamel. Here, we really just want to remove the dentine smear layer. We want to show the collagen fibrils. And the mineral removal is typically only about 5 micron, not much. So here, after you do the acid conditioning, you don't want to blow air on it. You don't want to air dry it because that action of blowing air will collapse the collagen fibril. So, in essence, that is what we are looking at. And then the second step is that the primer that we use in the next step is a hydrophilic substance that will penetrate and wrap itself around these collagen fibrils. So what we want here is for the fibrils the primer to really get into the space that has been created to at least matching the depth, because if they're not at the depth of what you've cleared out, that gap there is what can cause postoperative sensitivity. So if you're doing these steps individually, very important to not over etch the dentine, have a very moist, glistening dentine surface to work with that you haven't blown and collapse the collagen fibril. And then as you're applying the primer, you also want to really vigorously rub it for 20 seconds to try and get that primer as deep as possible into interlocking that space and to reduce the post-op sensitivity. So personally, what we're talking about is very technique sensitive. So later on you will see, and I'm quite jumping ahead, is my conclusion is self-etch works better than your separately conditioning the dentine scenario in 3 steps, because the chemical constituent just allows it to remove the dentine smear and also already prime as it goes to ensure that you don't have that sensitivity issue. So then finally is the hydrophobic layer of the bond can go on top. So reviewing all these steps, that's why you can see here on this chart, any of the self-etched is probably preferred from a dentine bonding perspective. Other things to really consider is to ensure that the quality of the dentine as well. Just like we will review the quality of the enamel, the quality of dentine is also very important. And here in the electron micrograph, you can see that in total edge, the depth of what you remove around the dentine tubules is a lot more uneven. But the self edge, as I mentioned before, as the acid conditions the dentine, the primer also reach the same depth and then lay on the bond that it attracts. So therefore, it has a lot less sensitivity issue and a little bit more less technique sensitive for those purpose. So here's a summary of the dentine bonding protocol. But just as a quick infill here, so with regards to composite, if we encounter any composite, we have to remember that old composite are harder to bond to because they just don't have as much of the double bond anymore of the carbon. So, and we need those in order to wet and adhere to the new composite again. So there are a few things, while we say there are a few things you can do, including maybe using a sandblaster on the old composite surface, using a silane agent to wet it. One of the things that I personally would prefer to do is if that particular composite is of age, then remove it, check and report the integrity of the tooth and the sound structure underneath, and replace it. So now this becomes a fresh new composite that is more easy to bond to. So finally, we are ready to really talk about what do we do with the restorations. So broadly speaking, most of tonight we're talking about glass ceramics that we can prepare to bond, because we can actually prepare them by, again, acid etching using hydrofluoric acid for like 9%. And you can etch this for 2 minutes, and then we will be able to remove the glass structure, and then we would do 60 seconds for feldspathic and 20 seconds for Emax to really rinse it off. Okay, and we let it to air dry. So you can see here that before the etch, the ceramic surface is a lot flat. After we remove the glass face, it has that micro retention. So then we will be able to apply a primer. So typically this is a silane agent that wets the surface, and then again we would allow it to air dry before we actually place the resin cement. When you are placing the resin cement, again we go back to the aspect of using a light cure resin, where you need to load enough cement so that as you place the veneer onto your preparation, you should be able to feel comfortable to puddle it in place, locate it, and see the excess of the cement come flowing out. Then you can be more certain that you have cemented this on without any voids, and that you fully have seated the cement. Because it is light cure, the advantage is that it does allow you a little bit more cleanup time, removal time, as well as that you can, when you feel ready to, you can also tack cure to remove it cleanly, because if you've got good finishing margin, then that removal of the cement can be quite predictable. And finally, once you are happy, you can then finish the cure. So because it allows for that, it does allow you to also work with 2 veneers at a time to really ensure that they are symmetrical and well aligned, and the most importantly is well seated onto your preparation, and so forth. So one of the aspects here that we all spoke about is I think is also the heat of the topic, and I'm just guessing some people will be asking in the background, for those who may choose to work with zirconia veneer, it's very important that in this circumstance you do not use any phosphoric acid to clean your your restoration after trying in before you cement. Ideally, if the laboratory hadn't already sandblasted, you can use your 50 micron alumina to do some sandblasting as a form of cleaning, as well as to create the mechanical retention and prepare the surface for bonding. And then you use an MDP containing primer to wet the surface. And you do not want that phosphoric compound to sort of compete with that, and that is why you would avoid using any of your chesite type of blue edge to clean that surface of the zirconia. In other etchable ceramic, that is not so much an issue. It's mainly just on zirconia. If you need to, if the laboratory had already done the sandblasting and you do not want to over sandblast your restoration, you can use other things like IvoClean or CerClean. So that's about all.
Fantastic. And we've actually covered, I think it was Zoe that covered actually the zirconia bonding protocol in one of our earlier webinars. I think it was on the topic of improving ceramic restorations, or all ceramic restorations. So we actually covered the zirconia in detail. So check out the webinar for that. A couple of quick questions for you, Agnes. In terms of bonding, obviously that veneer that you showed earlier, once the material was etched, rinsed and dried, there's no bonding agent that goes onto the veneer intaglio surface, isn't it? It's just the resin cement that goes onto it. Yeah. And in cases, there are some cases that we get where there's gingival recession, and so the patient will like to hide that and the often the incidental black triangles, which means we're bonding onto the root surface, which is bonding onto dentine. Do you have any reservations for that in light of what you just covered?
I think there are other things to consider. So whether I feel that there is good parameters for me to actually do dentine bonding, and dentine bonding can be reasonably predictable, although not completely reliable, and it depends on the cyclic loading, because you throw in there whether it's a bruxa or not, and I think there are definite limitations to it.
For sure.
Is it an absolute contraindication? Perhaps no. So there are just so much more to consider. But I think the basic fundamental is you have to question yourself as you prepare, onto this root surface. Are we talking about subgingival root surface? Are we talking about somewhere that you can control the dry field? Are we talking about just an exposed root surface? Or are we talking about actually looking at some other questions trickling in? You know what, with bruxes, if you see abfractions, I don't want to put my veneer on abfraction lesions, knowing that cervical region is already high stress. And I do see a lot of questions flowing in about bruxes. So if you really talk about moderate to severe bruxes, their bruxal facets wear means they have a very flat plane of worn incisal edges, worn cusp tip.
Yeah.
So it really depends on, again, going back to the reason why they inquire veneer. If they are inquiring veneer because they're concerned of their tooth surface loss, then we got to ask ourselves, are the veneers protecting them from their tooth surface loss? If they're using veneers predominantly because of just improve in color or a little bit on the overall form of the tooth, they still have decent enamel. They're not lengthening their incisal characteristics. They're not lengthening their cusp tip. I saw one of the questions is, would you be considering just felspathic on the label and not involving at all the incisal edge at all or other surfaces? Then if all the teeth contacts are on his own tooth and it's robust, all the bruxal facets are still his own tooth, then felspathic may be okay if feldspathic is unique in that it's a very weak ceramic. So for feldspathic, its success rate lies on having more than 90%, in my opinion, of the whole restoration on enamel. I'm not talking about the margin. Unless you're talking about something like lithium disilicate, which is a bit stronger in material strength, then now we're talking about a different kettle of fish where perhaps, if I have to prepare a veneer and around the cervical, I may have a slither of enamel, but I have prepped into the dentine. Aspects like this, perhaps lithium disilicate will have a better material strength in itself. We have to remember that sometimes as we consider occlusion, we keep bringing this back into veneers, but really this is a design restorative consideration for the mechanical resistance and retention form. So if we are talking about a bonded restoration, then the maximum bond strength will be compressive. And the bond strength will be most challenged if the force is applied along the plane, if the stress plane is along the plane of the adhesive plane. And this is why Ghada has mentioned before, overlapping the incisal edge a lot of the times put the force to become a little bit more vertically seating and dissipate that challenge along that surface of the adhesion. So I think holistically in the end, we can't actually just label one preference of a certain material to just generalized comment of bruxes. We do have to just consider what type of restoration overall can address the patient's concern, whether it's aesthetic form, and then we look at how this resistance and retention form can be met with what type of tooth preparation. And that really goes beyond, your veneer crown or partial crowns, that type of consideration. Yeah.
Dentistry is so multifactorial, sort of individual case-based, isn't it? So there is unfortunately no one answer that fits all. We're coming towards the evening, the end of the evening now, ladies and gentlemen. Thank you so much for still being with us. I know it's well past some of our bedtime. So for any of you that missed this segment or wanting to see some of the previous part, including was some questions on, can I get the QR code that you showed earlier? This webinar will be made available to watch on demand, usually within a week. So from our website. So watch out for that. Just some final remarks, guys. Any I was probably starting from you, Agnes, again. So while you're while the iron is hot, any summary, one sentence summary, or any take-home messages for our viewers tonight?
Well, I think there are lots to consider, and whatever you've considered and actually converse with the patient, if there are key points, do note them down in your clinical notes. It's not really a caveat, but I do think treatment would work more so in partnership. So I always think of letting the patient know, well, these are the things that we can do, but these are the things that you can do or you have to do. And if you don't do, then these may be the potential consequences. And in particular, I think for veneers, I cannot stress it enough that if you do encounter cases that is, as I say, not really, it falls into the category of necessary or appropriate in a public opinion or in the peer review opinion, then I think those particular cases, even if you have the best persona patient, you do have to just make sure you follow through all the steps of the discussion, the risk factors that spoke about, and the consent, so forth. I think it is just a good habit to build and install.
Be thorough, be methodical, and involve the patient in that treatment planning process. Zoe, how about you?
Well, I think one of the most challenging things is when the patient comes back to issue the veneers and they've got a lot of bleeding gingival tissue. So
yes.
coming back to a provisional phase, make sure that your margins are well polished, and emphasize to the patient the importance of maintaining excellent oral hygiene. So the chlorhexidine mouthwash, brushing, be meticulous with the oral hygiene, so we get nice gingival tissue contour when we come back.
Absolutely. There's nothing worse than trying to cement things
you can't.
in
You've
and
got to
then
postpone,
yeah,
take them off, put them back on.
it's horrible.
Sew them
Horrible.
off, yeah.
Horrible stuff. Johnson?
Yeah, I think good communication with your dental ceramist is important,
For sure.
especially if they do nice work, always have a good feedback. But if the color's not right, to take the photos. If contact's not right, to take the photos, and then so they can improve to make your life easier.
So constantly giving feedback to your ceramist for the good and the bad
And the bad,
cases.
yeah.
I completely agree. It's a mutual sort of a working relationship.
Yep.
And so we do have to foster that relationship.
Yeah, definitely.
How about you, Ghada?
For me, is to pick the right patient.
Absolutely.
Because I've been there, done that.
we all
So
have.
now I take my time. I try to
Yes.
understand the patient.
Yes.
It's not about what they say. It's about what they don't say.
Mm.
So it's like a sense.
Yes.
So it
That's
takes
sixth sense.
sixth sense. Takes a lot of experience.
does.
Even now, it doesn't matter whether the patient is nice and compliant. It can turn in 1 second if
Yes.
something doesn't go according to what they think in the
Yes.
mind. So for me, I take quite some time, especially for high static cases.
Absolutely.
Yeah, so that for me, that's the clinical skills. We all get better
We
with
do.
time. We get trained, but it's a lot of it is patient dependent. The success, because you could do, for example, when you're still learning, for
Yes.
example, as a dentist, many like you or a specialist, or you just graduated, you would do something very okay. Patient's so happy.
Mm.
You feel happy and you do amazing work, and then patient think, oh, what is that?
Yes.
And you already done everything. You've done the mock-up, you've done the composite resin build-up, you've done everything, and then it's, oh, but that was better before, but this was a bit better before, this was better before.
We've
So,
all been there,
yeah.
done that.
I think actually it is very true. When you do excellent composite resin, it is a challenge to actually
Yes.
get your porcelain veneer
To look better, yeah.
than your
It is.
composite resins.
Yes.
That in itself can be challenging, because the composite resin outcome often can have a bit more of a translucent, lustrous look,
It does.
especially when you first finish. But I think Ghada resonates really well. Now that she mentions it, I think I personally have a habit of intraoral mock-up or try-in. I actually would position them, and I walk away from the patient. I give them their own personal space, and actually, like, at least 5-10 minutes, or maybe I turn to my computer and I'm working on something, so that
DPR time. Is it?
I leave them alone to feel in their own comfort zone, looking
Right.
at the mirror. And I will say, oh, feel free to walk to the window area, have some natural light, and I'll come over in a minute,
Yeah.
So, you give them their personal space. And
Yes.
actually, when I make contact with them, it is a friendly eye contact, just to meet the eye and say, yes, well, let's have a look at this. But then my eyes will be fully focused on just looking at their teeth. And I do occasionally get them checking at me, to try and read my facial response as I look
Why are you
at them.
taking so long?
I think I just want them to be really in their own comfort zone.
Right.
To be able to honestly share with you what they think.
Sure.
Because it is very true what Ghada does say is, sometimes patients are very hesitant, especially when they know that you have dedicated all that time and perspective, and sometimes they don't really have the words to describe what further changes they might like.
Right.
And, of course, we're not that far off, but sometimes you know that, we're probably 80-90% there, but I can see that little 5-10% reservation. I wonder what it is. And you just want to be in an environment where you encourage that to come out.
open dialogue.
Yeah.
Absolutely.
Yeah, so actually I don't realize I do that until, but that is something I do.
And Johnson, how many provisionals do you do if the patient says, I'm still not happy, that's when you go, I think I don't think that's the patient for me.
Oh, I think through my initial mock-up in composite resin, before it sets, I can already change the shape and length and everything. So usually, if 2 sets of provisional in my hands, they're still not happy.
And they still have a list of 20 things that's wrong with this.
Usually it's due to change of mind. So if they
Right.
can change their mind all the time, so after 2 changes, I mean, I'm done.
Yes.
Yeah.
And that's speaking from experience.
From
of
experience,
being burnt.
Definitely.
Yeah.
Definitely. Yeah. If after 2, regardless how many I do, it's unlikely they'll be happy at the
Right.
final.
Right.
Yeah.
Right. So once again, I guess what the team is saying is that patient selection is so important. For everyone, so thank you so much for again joining us tonight. Thank you for your questions. My sincere apologies if I wasn't able to answer each and every one of the questions. But hey, feel free to send in these questions via that submit button, or I'm sure many of you guys have our email address or even my phone number. So please do not hesitate to send in your questions after this session if you feel if you would like to have some better answers. Once again, just a reminder regarding CPD certificate. If you'd like to receive one this evening, please scroll to the bottom and fill in your email address. Last but not the least, once again, I just want to say thank you so much for your support and your trust in us as a group. We're here to serve, and we're here to support not just your patients, but for you as well. So anytime if you have any concerns, any problems with how we're managing your patient, please do not reach out to voice out your concerns. And for any other questions regarding your teeth-related stuff, dental-related things, feel free to ask us any questions that you have. And with our collective resource and also sharing the space with many other specialists, I'm sure we can come up with half seemingly intelligent answers. So once again, thank you for joining us, and good night.